Okay. Evet, hepiniz hoş geldiniz. Bu 98. oturumumuz. Bugün İngilizce olacak. Evidence-based psychotherapies, yani kanıta dayalı psikoterapiler. Konuşmacımız Richard Mcnally. Onu da tanıyanlar çıktı aramızda ve arada da yorum yapacak, müdahale edecek, belki onun söylediklerine karşı gelecek. Daha evvel konuşma yapmış konuşmacımız Metin Başoğlu var ve moderatörümüz de Özlem Şeyda Uluğ. I'll start the next bit in English. Richard will start off by a brief description and then his slideshow, a copy of which I forwarded to the group. It doesn't matter if you haven't watched it. And then he'll follow it up for a while. If there are any immediate questions or let's say crucial questions, Metin and Özlem will be following them and could interrupt Richard and forward him the questions, but otherwise we'll follow up the slideshow and then give a break, 2-minute break at the end. And after we come back, depending on the number of questions, written or spoken, you need to raise hands, but you will be able to unmute yourself. And then once you're finished, please mute yourself again in case you have a phone call in the background which disturbs the meeting. And then Metin will give a brief presentation, and then we'll move on from there. Then we'll take questions written or spoken. If you have difficulty in finding the right or technical terms, you can refer them to Metin and he can do the translation. But you still need to write it, or you can raise your hand and speak it out. And they'll do the translation and then Richard will reply. Any questions? No? Okay. Atilla kaç kişi olduk? 31. Okay.
31.
I think, what time is it? Oh gosh, it's 11 minutes already since the start. Okay. Okay, Richard, let's start then. Huh? You need to unmute yourself. I'm asking you to unmute yourself. Okay, fine.
Let's see here. Yeah, okay.
Okay.
Try to do the share here. Let's see here.
Yeah.
Okay, can you see my screen?
Metin bir dakika, yazılı ortadan sorma lütfen Metin. Peki sor hadi artık. Richard, just one moment. Dinliyorum Metin.
Özlem was going to introduce Richard to the audience.
Oh,
I'm sorry. Yeah, you're right. Özlem, why don't you warn me? I mean, okay, I apologize for this. Okay, Özlem.
Okay, I'm going to introduce Dr. Mcnally and Dr. Başoğlu to all of you. I'm sure you've all read their bios, but I'm just going to summarize them briefly. And I'm not going to tell about the dates because I don't want to mention their ages. So let's see. Dr. Mcnally graduated from psychology from Wayne State University, and then he's got his PhD in clinical psychology from the University of Illinois at Chicago. And after that, now he's a professor and director of clinical training in Harvard University. And he has lots of publications, researches, and many of them are really crucial, and lots of citations. He's mostly studying on anxiety, and he's an important person on the subject. So, as well as Dr. Başoğlu, and I'd like to, if I'm talking about Dr. Başoğlu now, he's a graduate from Hacettepe Medical School, and he had his psychiatry residence in Istanbul University. And after that, he started to work in Cambridge University about trauma studies. And he also has lots of publications and researches about trauma, torture. And what they have common is that behavior therapy, we might say, lots of publications and citations. And what we will be witnessing today is that there are differences, I suppose. I can say that we will watch an amazing debate today. Thank you.
Okay, Richard.
Your speaker is off.
Oh, there we go. Okay. You said, so you can't see, it says anxiety on the top. Can you see that? No.
We don't see anything on the top.
All right. Okay. What's going on here? Let's see here. Okay. I'm not trying to cause myself a panic attack or anything like that.
Did you, is it open on your computer screen?
Yeah, it is. Yeah.
Okay.
What the hell's going on here? Okay. All right. Where is this darn thing here? Yeah, I've got it open on the screen. And now.
And then you hit the, you're co-host, right? You are, right.
So
and then you hit the share screen button.
Yeah, I know. That's what I was doing there just a second ago. All right. Yeah.
Shall I come over there and do it yours?
Yeah, I can't. I'm not picking it up on the. Can you see it now?
No.
Oh my God.
No. Come back. Let's just do it slowly.
Yeah. Slowly.
Stop share. Stop screen share.
Boom. All right.
Okay. Now touch share again. Hit share screen. What do you see in your? You should be seeing your presentation on your.
I am. Yeah, I am. Yeah, I can see it. Yeah. But you can't.
No.
No.
But we can see the mouse.
Okay, who can share? Only host all. Oh, wait, let me try something here. Okay. Let's start with someone else's. Okay, can you see it now?
No.
We
will let you know when we see it.
Yeah, all right.
I think if you move to your slides, we will be able to see your show.
Yeah. Yeah, that's weird because I can see it just fine. Let's see here. Okay.
Okay, great. We see anxiety.
Okay,
we
what I did.
We just see the word anxiety.
That's it. All right.
Okay.
Okay. Let me see here. And you can hear me okay, right?
Yes.
Okay, good. Okay. Yeah, I had to switch to all participants to show it for some reason. I've not seen that one before. I did that and boom, here it comes. Okay, good. Thank you for inviting me to speak to your group here. I'd love to be in Istanbul doing this live. I've been there, I think 3 or 4 times with Metin, with Cengiz, and Cengiz Kilic, who I think is in the audience, I think. Yeah, so what I wanted to do today here is that Metin was asking me to talk about psychotherapy research and what constitutes evidence-based interventions for mental disorders in the psychotherapeutic range. And my first thought was, oh my God, this is an enormous topic. And I am not a psychotherapy researcher myself. So I'm not really carry a union card as a psychotherapy researcher. The therapies will be describing, I've been a therapist who's used these to treat patients personally and supervised their treatment as well with trainee clinical psychologists. But most of my research is basic research in the anxiety disorders. But that said, I said, well, maybe what I could do is just begin by sort of orienting folks to anxiety and the anxiety disorders, or at least a selective group of them, for which behavior therapy and cognitive behavior therapy have racked up some pretty good successes. There are really no panaceas in this field where everybody responds as if you're giving somebody an antibiotic for a strep throat or something. Not quite like that, but there's been a lot of progress relative to where we were, say, in the mid-1960s or early 70s. So just to begin, think about anxiety, first of all, just the emotional state. It's almost certainly an evolved adaptation. And by that, I mean, it has sort of evolutionary significance. It promotes survival and presumably fostered fitness in ancestral populations, right? And so our ancestors are those who were sufficiently anxious to be mindful of the threats that were present in their environment, back in the Pleistocene, and therefore they were able to reproduce and go on. So anxiety then is a very useful emotion. It's future oriented. It facilitates detection of threat and motivates defense against threat. So we hear this, that it motivates fight or flight or freezing in some certain circumstances when escape is impossible. Now, so then the obvious question is, well, when does anxiety become a disorder? When do we take this evolved, normal, very useful adaptation for navigating our world and surviving and passing on our genes, etc.? When does it become a disorder? Well, there's no clear-cut boundary here, but there is sort of a fuzzy boundary that can help us. When a person's fear of the threat is disproportionate to its magnitude in terms of either the probability of the feared event happening, or how bad the event would be if it were to happen. So people with social anxiety disorder would be absolutely terrified of the possibility of blushing in public. God, I'd be mortified if I did that. Things of that sort. Or people with generalized anxiety disorder may fear that they're going to develop some fatal cancer, yet when all the evidence is, in fact, they're quite healthy. So when it's disproportionate, sort of excessive, so to speak. Then the second one is its persistence. So the person's, it's not just a brief moment of exaggerated anxiety, exaggerated sense of threat, but it's persistent. And you see in the, say, the Diagnostic Manual Mental Disorders, the DSM of the American Psychiatric Association, that sort of defines and tabulates and provides a criteria for diagnosing disorders. They'll often say, well, there has to be a persistent threat, at least 6 months or so. They have these sort of rule of thumb. And then finally, it's impairing. And so the person either has to be very, very concerned about having this excessive anxiety that persists, or more typically, it gets in the way of their life in important ways. It gets in the way such that it interferes with their ability to work, to go to school, it interferes with their social relationships, etc. And so you can see, for example, how someone might have intense fear that's persistent, but it's not really interfering with their life. Then, this may not even qualify as a disorder. One sort of amusing example is one that Dave Barlow, who's working on panic disorder, I'll mention later was telling me about once. He used to work in Albany, New York, and that, up in New York State, north of New York City, where they get tons of snow every winter. And there was a woman he had there who had an automobile phobia, driving an automobile in the winter. I mean, and it really was interfering with her life, because if you can't drive in the snow and you live in Albany, you got a problem. You know, it's going to really get in the way of your life. And so what happened, though, she was instantly cured of her phobia. What did she do? Well, she and her husband moved to Miami, Florida. Boom, still fears driving in the snow, but it's no longer impairing because it does not snow in Florida. You know, so this is sort of an example how where you know, when the rubber hits the road, are you really talking about the impairment? Is this really getting in the person's way or not? For example, a lot of people will have fears of, say, snakes. Yeah, but they live in a big city, so they don't go to the zoo, they don't go to the herpetology exhibit, but you know, they can pretty much navigate their life without without dealing with snakes. And so these are sort of the general criteria. So when we're talking about, say, devising treatments for anxiety disorders, we're really talking about the folks who've got this disproportionate, persistent fear that's really, really a problem in their life. Okay. So then there's the issue about fear versus anxiety. I mean, most psychologists and neuroscientists point out that these are slightly different. There's different regions of the brain that support these two different emotions. But the practical distinction between them is that anxiety is very future oriented. So you're being anxious about threats that are down the road, typically, you know, next week or even tomorrow. It's that you're worried about something, giving a speech, perhaps. Whereas fear is dealing with the mobilization of defenses right now. You know, so the threat is quite imminent. So someone, for example, who's struggling with panic disorder, they may see their heart beating fast, et cetera, and they have a hard time breathing. So, oh my goodness, I think I'm going to die of a heart attack now, right? So the threat is very imminent. Then you're dealing with fear. Anxiety, it's a little more distant, so to speak. So it's an issue of a sort of proximal threat, one right in your face, so to speak, versus one that's more distal. Either in terms of spatially or in terms of time. Okay, the first of the disorders I'm going to mention here, panic disorder and agoraphobia. Agoraphobia etymologically is, you know, fear of the agora or fear of the marketplace in ancient Greece. You know, phobia specialists, they like to dream up all of these funny names, you know, acrophobia, agoraphobia, whatever. But it's not really a fear of the marketplace per se. Rather, what agoraphobia really is, in the vast majority of cases, is fearing to venture into situations. Yes, it might be the town square. It might be a shopping mall. It might be going in an airplane or sitting in the back of a Volkswagen Beetle where you feel trapped, going to church. You know, the situation, what the person actually fears is having a sudden panic attack in circumstances in which it would either be embarrassing to have one, possibly dangerous, you know, driving a car on the expressway in traffic and suddenly panicking. Person fears, oh my God, I'll try to drive off the road and crash into somebody, et cetera, et cetera. Fear of, so agoraphobic individuals fear flying in airplanes, not because they fear the plane's going to crash, possibly, like someone with a phobia, a specific phobia of airplane travel, but rather that they might have a panic attack and there's no way of escaping. You're trapped in the airplane. Okay. So recently, 2013, the DSM, the American Psychiatric Association, for reasons I don't think made much sense, they sort of separated these two conditions, panic disorder and agoraphobia. But they very often go together, especially in clinical situations. So what the panic attack is, people have to have these sort of abrupt surge of intense fear, right, or intense discomfort that reaches a peak with minutes. Oftentimes it's just seconds, right? So the idea here is that the person may or may not be anxious, et cetera, and all of a sudden, whoosh, you know, the fear goes, physiological sensations, and the fear goes up quite a bit, and then eventually sort of slows down and goes away. the person can be anxious. It can occur from a relatively calm state. But oftentimes patients will say, it seems to come out of the blue. They seem to be mugged or surprised or ambushed, if you will, by this physiological arousal that frightens them. And so, in the DSM, you think it was a bunch of lawyers, not psychiatrists, who wrote this thing, but you have to have it's all this bureaucratic language. You have to have at least 4 symptoms for a real panic attack. Whatever. Okay. These would be like heart palpitations, pounding heart, sweating, trembling and shaking, sensations of shortness of breath or smothering. People, they feel like they can't breathe. They can't get enough air. Sometimes feel like they're choking, and they'll start trying to breathe more. And what that actually does is causes hyperventilation, which causes even more symptoms. So the more they try to fight against and struggle against these rising sensations, the worse it gets. Sometimes the muscles in their chest will get really tense and causing pain, and they, oh my goodness, it's a heart attack, right? But it's not the typical characteristic, pressure, weighted pressure of a heart attack. So, but somewhat different. Sometimes we get nausea or abdominal distress, and many patients feel that they're going to get that they're going to faint or collapse. They feel dizzy and they're lightheaded, and often because they're over breathing, hyperventilating, breathing in excess of metabolic needs. So they're sort of blowing off all this carbon dioxide. And people actually don't faint during these attacks. I've never seen it, mainly because their heart rate's too high. People who have a fear of blood and needles, they often do faint. They experience a little bit of an increase in anxiety and fear, and then whoosh, their blood pressure just plummets. Blood pressure and heart rate goes down, and they faint. But the heart rate is typically fairly elevated in folks with panic attacks, and so they're very unlikely to faint because they're getting plenty of oxygenated blood in the brain. Chills or heat sensations, paresthesias. So sometimes you get this numbness or tingling sensation. Some people say, oh my God, I'm having a stroke. I have a neurological condition. But actually, you can produce a lot of these sensations at home in your spare time just by over breathing, like going, doing that for about 2 minutes and stopping. And all of a sudden you get lightheaded, you get disconnected from your body. You have tingling sensations. You can produce a lot of these things. The derealization of feelings that you're in a dream state, you're disconnected from reality, or depersonalization, being detached from one's own body. These sorts of things also can be produced by hyperventilating. So once this attack is going, the person's trying to get more air, they hyperventilate, then they get these sensations. And a lot of times when folks are having these, just think, oh my goodness, I am becoming psychotic. They're afraid they're losing their mind, that they're going to go crazy. Of course, that is not how people typically develop psychosis. Schizophrenia has a long lead-up period, etc. Fear of losing control, going crazy, fear of dying. And so what a lot of the psychologists suspect that what happens is that you get just normal physiological variability. People vary in the degree to which they experienced skipped heartbeats or what have you. And then they react fearfully to these sensations, which then tends to make the sensations worse, which tends to give the impression that, oh my gosh, my interpretation that I may be having a heart attack is real. And of course, that anybody who thinks they're about to die gets even more frightened, which makes it worse. And there appears to be kind of like a spiraling effect. So some of the panic attacks are sort of canonical, classical ones are unexpected attacks. Can you see my my little cursor here?
Yes.
You can. Okay, good. Okay. Yeah, so some of them, the ones that come out of the blue, where the person says, my goodness, I was sound asleep and suddenly I woke up in a panic attack. So you find these sorts of things. When people develop panic disorder, which is really frequent attacks accompanied by the fear of the attacks, and they start adjusting their life and avoiding certain situations, and because they expect to have attacks in them. So if you've had panic attacks in the grocery store, or driving an automobile, or being in elevator, whatever it might be, you might start avoiding them. But when you have to go into the situations, you have another attack, and oh my gosh, it confirms it. Okay. Now, the way that a lot of the behavior therapists and cognitive behavior therapists treat this, like I said, agoraphobia was originally seen as a fear of open places, or et cetera, But if you see it as sort of a fear of the bodily sensations that are part of a panic attack, it's a kind of a fear of fear, so to speak, or at least fear of those sensations. And so a lot of the treatments for panic disorder today, panic disorder and agoraphobia, is you're treating the fear of the bodily sensations, and showing people that they can increase them or decrease them with some simple methods that I'll mention, and then doing exposure to situations that they've been afraid of. But one of the first things that is typically done is correction of misconceptions. A lot of folks who've had panic attacks, and you see clinically, sort of misinterpret the significance of what's going on. So, for example, I mentioned that they think that, oh my gosh, I'm going crazy. I might become psychotic. Or even if I don't become psychotic, I will lose control and do something dangerous. I will jump in front of the subway train in the midst of a panic attack, not to commit suicide, but just because I lose control over my mind. Or I will become psychotic, and I'll be put in an inpatient unit, and I'll have a straitjacket on, and I'll never get out again. Or I'm having a heart attack or a stroke. And it's easy to see where some of the bodily sensations that are part and parcel of panic could be misinterpreted that way. And so there's some cognitive correction, sort of an educational component that is usually included in the early phases of treatment. And then there are ways that you can increase and decrease symptoms. Now, the idea here is not to say, okay, I'm going to remove the symptoms, et cetera, because God forbid, should your heart beat too fast, it might harm you. No, that's not what we're trying to do here. But the respiratory control, this is teaching people how to breathe diaphragmatically, not deep breathing, but breathing with their diaphragm rather than their chest, and breathing through their nose, not their mouth. And then so you can lower symptoms, and if you hyperventilate, you can increase them. So you're kind of putting the person in the driver's seat. You're putting a person who has no agency, doesn't have a sense of control and mastery of their situation, because the attacks are coming out of the blue. They feel helpless against them. And by teaching these symptom techniques, you can increase the symptoms, you can decrease them, you kind of move it around. So it imparts a sense of agency. Now, the interoceptive exposure, this fancy term, what this is referring to is, just like a person, say, with a dog phobia, fears being exposed to dogs, or height phobia, fears being looking down from high places, the panic disorder patient has a fear of their own bodily sensations, dizziness, rapid heartbeat, et cetera. So what they do, they get desensitized to the bodily sensations. The therapist shows them ways of increasing them. So, for example, doing the squats, moving up and down to make their heart rate go faster, running in place briefly, or one of my favorite ones is sitting in a chair that spins around and spinning around in the chair like that, and then standing up, confronting with dizziness. The feelings of dyspnea, like I can't get enough air, holding one's nose and breathing through a straw. So all of these things produce these sensations. And the more the person is confronted with a stimulus that is not truly dangerous, but for which they have considerable anxiety, they sort of lose the capacity to respond fearfully. They get sort of desensitized to their own bodily sensations. And so the interoceptive exposure is directly targeting that. The fact that they can increase the sensations, they can decrease them, et cetera, imparts a sense of control. And these people do not feel in control of their own body, for crying out loud. So this does that. So you desensitize them to the sensations. Now, the behavioral experiments are ways of where some of the patients will say, well, you know, if I do X, then Y will happen. You know, so if I really, really spin around in a chair, hyperventilate, then I stand up suddenly, I will collapse. Now that's a hypothesis. That's something that we can test, right? You can test that. And so the behavioral experiments are things that you do with the patients to test the validity of their hypotheses. You know, so for example, some patients will say, oh my gosh, you know, I was in the supermarket the other day, in the grocery store, and I'm standing in line, I got my cart, etc. And all of a sudden there are people in front of me, people behind me. And all of a sudden I started feeling tense. I said, oh my God, I'm gonna have a panic attack. And they got more anxious and they had a panic attack. And then the patient says, you know, oh, then I grabbed onto on the cart, onto the metal cart. I had to hang on like that. If I would have not have done that, I would have collapsed right there. And so that's a hypothesis. Well, you know, if you get really, really dizzy in a panic, will you collapse if you're not holding on to something? Or the patient who believes that if I don't get outside run out of the church as fast as I can, I'll suffocate. Well, let's see what so the behavioral experiments are ways of designing and testing, just like a scientist would, prediction of what will happen. If X, then Y, well, you think that will happen. So they get direct experience with this. And what this seems to do, you know, is that the patients will, they may intellectually realize, oh, you can't collapse if your heart's beating fast or whatever it happens to be. But actually doing it in real life with oneself can be stronger evidence, right? They're like being doubting Thomases, so to speak. But now when they do experience it themselves, that has greater validity, and that can help them reduce their anxiety sensitivity, their fear of fear. Finally, the individuals who have developed agoraphobia, which is a lot of a fear and avoidance of all kinds of situations in which, God forbid, panic attacks might occur. So the in vivo or real life exposure is going into these situations and trying to experience some sensations, maybe breathe a little bit or whatever it happens to be, and then remain there until the sensations go away. Now, for a long time, we thought that the patients should never leave a place when they're really anxious. And now it seems that knowing that you can leave it if you have to, quote unquote, have to, is okay as long as you go back in, right? And so the idea here being to doing the exposure until you learn that you can master the anxiety, you're back in control of this, and because of that, you lose your fear and the situations become less provocative of a distress. So this is kind of a standard package. There's, you know, David Clark, for example, who's a professor at the University of Oxford. He's got, he devised a program very much like this. And one of the things in the UK with the National Health Service has been this idea of trying to make things as efficient as possible, right? And the more you can manageably pack into a session and to make it brief but just as effective, that is what his goal has been. And they've been doing some very interesting work here that takes us a little bit outside of this. We can pick up on this later. Some really cool things going on in England and Wales in recent years about getting efficacious treatments in the National Health Service. But anyway, so his original version here was 12 weekly 1-hour sessions. That's kind of, that's on the long side. And then they've done a briefer version where they have self-study stuff on manuals, the vicious circle where you detect symptoms, you get frightened, they get worse, you get more anxious, etc. Challenging thoughts, alternative interpretations of symptoms, et cetera, et cetera. Oh, the safety behaviors. That's what this refers to is you have some people who will be able to go into phobic situations, so to speak. But as long as they have some sort of, if you will, superstitious sort of talisman with them, sometimes it might actually be something like a bottle of Xanax, triazolobenzodiazepines, medication that acts quickly should they get anxious or have a panic attack, they take a pill. There even been cases of people who had even taken empty pill bottles. As long as they had the bottle there in their hand, they felt safe. It's like almost a superstitious behavior, but this reduces their anxiety sufficiently so they can go into the situation. I was interviewing one patient once and who had panic disorder, and I asked her about situations in which she is afraid to enter or activities she's afraid to engage in because of her fear of panic. She said, "Oh no, I can go to the store, I can drive on an expressway, I can do all of those things." And then I asked her, "By yourself?" "Oh no. It's only if my husband's with me." I go, the husband is a safety signal, right? Yeah, and sometimes people have very arcane things. A colleague of mine at Pennsylvania, University of Pennsylvania, Diane Chambliss, told me about a patient she had who had pictures of her pet cat in her purse. And if she started to notice the sensations like she might panic, she'd pull out the picture and say, "Oh boy, what a beautiful cat I have. Boy, this is really a wonderful cat." And so she was distracting herself. But I mean, a photograph of a cat can't actually prevent a panic attack any direct way, but it reduces the person's anxiety. So sometimes then, if people do have these things, right? Or like the lady that I mentioned in the grocery store, had I not have grabbed onto the cart, I would have collapsed, right? So the question about, well, gee, why didn't you have a heart attack? Or why didn't you collapse? Why didn't you faint? Why didn't you go crazy? What do you think happened that prevented that from occurring, right? And sometimes that will reveal that they've got these little safety signals and all sorts of things, et cetera, et cetera. So eventually you want to fade those so the person is confident that they can do things whether or not they have a cell phone with them or a bottle of pills or what have you. Okay, so Clark, you see here his, and this is a particular study, I'm not going to dig too deep into the graphs here, but you got these, David has got sort of a composite measure of, for example, panic, the fear of panic, avoidance behavior, et cetera, et cetera. And the idea here is that the pre and post treatment, you can see, it really goes down quite a bit, both the full cognitive therapy, as he calls it, or cognitive behavior therapy. And the brief version does just as well. And say, oh, that's really great. And this is imipramine, which is one of the major psychopharmacologic compounds. It was originally shown to be helpful against panic attacks. And Dave Barlow, he did one of the largest studies actually on this, a very, very well designed study. Dave is a now professor emeritus across the river, Charles River from me over in Boston University. And Dave did, this is a common thing that people do these days, is where you have different folks who specialize in different approaches, say medication versus psychotherapy, getting together and having one of these collaborative studies where you test, compare different treatments across different sites, right? And so in this particular study, Dave was originally at the State University of New York at Albany, now Boston University, a site for behavior therapy, cognitive behavior therapy. Jack Gorman, a psychopharmacologist at Columbia University. Kathy Shear, she was at the University of Pittsburgh at the time. Now she's at Columbia, and who was a psychotherapy researcher, psychiatrist, and Scott Woods, a psychopharmacologist down at Yale. And so what they did, they said, okay, there's this concern you might get what's called an allegiance effect. So people who design a psychotherapy can really be good at it, right? They're the real experts on it. They've written a manual, how to do this, how to teach people how to do CBT for panic disorder or agoraphobia, for example. And then you got the psychopharmacologists who become really good at prescribing and being able to increase dosages without producing side effects and managing the medication regimen, right? People have real expertise in these areas. Sometimes people are both, but usually it tend to be one or the other. So what these guys did, they said, okay, what is the most efficacious treatment for panic disorder? CBT, imipramine. Imipramine was the original one that Don Klein had, Columbia psychiatrist, who had he sort of focused on that. And that was sort of an original intervention, and they use different four sites. And so basically what you do then to find out whether the psychotherapy or the medication works best is you train people up at each site to do both, right? That's how you do that. And it took 7 years to complete this darn study. And so what they did, they had, first of all, you have the possibility that maybe the best way to go is do the CBT and the medication, right? So maybe it will cover your bases, so to speak, but it maybe has an additive effect, maybe an interactive effect, where you get even a bigger effect than either one alone, or et cetera. And so what they did, they had one condition, people are randomly assigned, and this is one of the key issues, right? Is to randomly assign folks with the diagnosis to any of these conditions, right? So you had some people who got a combination of CBT and imipramine, and then you got folks who just got the imipramine alone, another group that just got the CBT alone, a group that got a pill placebo. And that was the original design, and that's usually the one you see in psychotherapy research when you're comparing a therapy to a medication. I should also add parenthetically, the psychopharmacologist will also do studies with a pill placebo and 2 or more medications. And psychotherapy researchers will do studies where you've got a wait list or a supportive psychotherapy versus CBT versus another psychotherapy. So the model is basically the same. But what happened in this one is, like I said, usually see, say, a psychotherapy, a medication, a pill placebo, and the combination. Barlow was telling me that he was at some conference when they first started the study, and some statistician comes up to him and says, Dr. Barlow, I am sure that you probably have a cell in your design where CBT is combined with a pill placebo. And he goes, well, we usually don't do that. And the statistician says, well, gosh, maybe if somebody is swallowing anything, and whether it's a medication or a sugar pill, what the heck? Maybe that will have an effect when combined with CBT. And so they thought, whoops, not a bad idea. And so they eventually recruited another, while the study had started, they assembled more people for a CBT plus pill placebo treatment. This is a really interesting twist, and this is one of the few studies that have done this. In fact, I'd be hard pressed to think of another, because what often happens is the researchers say, we want to have enough statistical power. So if there are real differences among these groups, we can identify it statistically, make a reliable distinction here. And so are we going to have enough patients to have the luxury of doing a CBT plus pill placebo? So a lot of times this gets skipped, and we'll see that this these guys are glad they actually included it. So what they do here, they've got tons of measures in here, and like the David Clark slide, sometimes what people will do, they do the individual measures in the article, but then we'll sort of combine them to get a end state functioning with their really have a good response, et cetera, et cetera. And you see there, you find that the CBT and the imipramine was better than the imipramine alone, which is right here. So this is the response to treatment. So about half of the people did really well there. The placebo, 3.75. One of the interesting things about depression and about panic disorder is that people will often seek treatment right at their worst point. And then you get the so-called regression to the mean effect, whereby that people will tend to drift downward if they're ill, so to speak. And so they tend to get better in any event to some degree. There's normal fluctuations here. And so, and you can sort of see this. So the pill placebo actually worked here as well. And so, and then the CBT plus the imipramine better than pill placebo, et cetera, et cetera. But the conditions look quite similar, right? So it looked like it was an interesting thing to do here. But what happened here in the long run at the follow-up, once they withdrew the medication, now this graph is a little bit different here. What's going on here is this is the people who relapsed. So the people who had just gotten the CBT alone, this 17.8% relapsed. The people who had that should be CBT, not CBI. CBT plus pill placebo, They also had a relatively low rate of relapse. We're talking about 40%, and I don't have the percentage on this one, it got cut off, but this is about 55%. So it was a lot more. So if you had, the imipramine suppressed the panic attacks. Once they went off of it, 40% of the people relapsed. They were back having panic attacks again. And what was interesting here on the far left, the folks who had gotten the CBT combined with the imipramine, when the CBT stopped and they were not taking the imipramine, they actually relapsed. And so if you take a look at the folks who either had a pill placebo plus CBT or just got CBT alone, what seems to be going on here, this is clearly a pharmacologic effect here, that somehow suppressing suppressing the panic attacks with the bodily sensations that come to it, apparently attenuated the patient's ability to master the fear of the sensations. That's one guess, because when you go off the imipramine, the sensations come back. Having gone through CBT did not help a lot of these folks remain well. So it was sort of an interesting sort of finding here. Okay. Now, what Barlow is doing recently is something called the Unified Protocol. And this is this new approach to psychotherapy, actually. Because from those of you who are familiar with sort of the clinical psychology, psychiatry approach, we have got different diagnostic categories, and each one has got evidence in favor of, for example, what is the best way of treating it, et cetera, et cetera. Well, so there's been these evidence-based treatment manuals. They're not rigid sort of cookie cutters, right? But they're kind of like the strategy I showed you with the correcting misconceptions, the interoceptive exposure, blah, blah, blah, blah, in vivo exposure, and the like. So they're a flexible but teachable framework for how to treat each disorder: OCD, depression, panic disorder, social phobia, social anxiety disorder, etc. Now, a lot of these conditions tend to be comorbid, to use the medical expression. That is to say that a lot of individuals who will meet your criteria for panic disorder and agoraphobia, they often are depressed. Having panic disorder is depressing, quite frankly, especially with agoraphobia. They may also have social anxiety disorder. So it's uncommon that they have only one thing. So now, if you are saying, what I need to do as a ethical, up-to-date, scientifically oriented practitioner, therapist, is to use evidence-based practice, then what that would seemingly entail is that you got to master the protocol for depression, master that one for agoraphobia and panic, master the one for social anxieties, or master the one for OCD, et cetera, et cetera. And if someone has a diverse clinical practice, wow, that's just a lot of different methods to master. So what Barlow was saying, he says, well, suppose we turn this all on its head. Suppose we say, okay, what are some of the things that are transdiagnostic? And there are certain problems that may manifest differently, but appear sort of across a lot of conditions. And so he says, well, this unified protocol, the UP, as they call it over there at Boston University, the UP, so what this is, it's a modular sort of system that tries to target things that kind of appear in a lot of different conditions. And so this would be a very efficient way of say, dealing with several comorbid conditions on its own. So the idea here is that how people respond to emotions can be problematic, right? And so this is what they're trying to do is to deal with emotion regulation, fear of experiencing emotions, avoidance behavior, mindfulness, attention, staying in the moment, not projecting yourself into a threatening future, et cetera, et cetera, et cetera. Now, the original goal for this, when Dave was telling me about this some years ago, was that they were seeking, going to do a non-inferiority design. And my first thought was, gee whiz, that doesn't sound very ambitious. Well, we got this new treatment and we just don't want to be, inferior than the other ones, you know? Don't you want to have something that's even better than all of them? No, in this case. But once I realized what he was talking about doing a non-inferiority trial, I mean, despite the fact that it doesn't seem like an ambitious goal for a new therapeutic approach, it does have a good point. So in other words, if you have a protocol that actually can hit the core problems that cut across several often comorbid conditions, say depression, social anxiety, and panic disorder, great. Because what you have, because even if it's not inferior to the specific protocols, some of which I was just describing, that's not bad. Because now suddenly you've got a more efficient way of doing business, right? So you can actually deal with several conditions at one by trying to targeting the elements that are in common across them. That's what the non-inferiority thing is about. And so they have introductory modules. Some of them are just simply enhancing motivation. There's a motivational interviewing approach that actually comes out of the alcohol field to motivate people to work hard at changing whatever it happens to be, whether it's drinking problems or confronting emotions that you're afraid of. They also, the idea that I mentioned right at the beginning, that about the adaptive importance of emotions. They're functional, right? They're evolutionarily conserved functions. It's only when they get disproportionate, et cetera, are they truly a problem. And so this mindful motion awareness, sort of staying in the moment and being able to, not project outside of it, just sort of focusing on the here and now. Cognitive flexibility, the way of seeing the phenomena in different ways rather than, sort of a rigid way of approaching everything. Identifying, preventing problems of emotional avoidance, all right? And so whether it's you're avoiding emotions or avoiding situations in which panics can occur, et cetera, a core element of that. And there's where the exposure element plays a major role. And awareness and tolerance of emotion-related sensations, right? Interoceptive and emotion-focused situational exposure, so on. So you see some of the elements that pop up in other conditions, and depending upon what the situation is, whether it's social situations or agoraphobic ones, you're hitting it that way. So what they did, they had a randomized controlled trial, right? So they're randomly assigning people to either get the unified protocol versus a syndrome-specific treatment versus a wait list, right? Because a lot of people, well, they'll just get better with time, right? And so the wait list controls are ones where they do the assessments and then they're assessed again when the other folks who've been randomly assigned to the active interventions have finished their trial. Then you're assessed again to see whether or not to compare it against just the natural recovery, if you will, of the disorder. The one with panic disorder, with or without attendant agoraphobia, obsessive compulsive disorder, and social anxiety disorder, and generalized anxiety disorder. What they found was non-inferiority. In other words, that the unified protocol was doing just as well as the more specific ones, like in vivo exposure and response prevention for OCD. More on that later. Or the panic one I just described. There were fewer dropouts for the unified protocol. So this is one. So here was an interesting situation. It's not entirely clear why that's the case. I don't know. But this actually was a relative advantage. So people actually completed the programs. I should mention parenthetically that there's two ways of evaluating a psychotherapy or drug therapy for that matter. Is that you randomly assign people to these different conditions, right? And then they go through the intervention and then you assess them again, and we could look at the relative improvement. Of course, now some people drop out. And so what do? Do you consider them as failures, et cetera, et cetera? And so there's two ways of doing that. You can either take the last measurement that you had on the person and carry it forward and include that person, or you can only deal with the people who completed the full trial, right? And so they answer different questions, right? So if you're saying, well, what is the probability that someone is going to recover or get much better if they complete the full course of treatment? Right. And so then you're dealing with those who completed the full course, showing the therapy at its very best. Or are we going to say, well, we'll just do the people including the people who eventually dropped out, will take their last measure, carry it forward. And so that answers the question, well, if somebody walks into the clinic off the street, you don't know whether they're going to drop out or complete the protocol. What is the probability of that person recovering or improving? So at any rate, but they had fewer dropouts with this. And so you see, this is it. So you get the wait list is going here. This is the ADAS-R. That's that's a measure overall. The CSR, that's sort of a general measure of pathology in this case here. To go into the details here, but people, you see, they get better with the wait list. They get a little better, but not that much. Okay, so this the unified protocol, there's a lot
Excuse me.
Yes, sure.
Excuse me.
Yeah.
Before we go on to another topic, there's a question from our audience, and I think it's relevant. You talked about 2 studies, and speaking of David Clark's studies, did they ever find evidence to show that what worked in CBT was cognitive interventions and not live interventions used together with exposure treatment does not have additional effects? So what's the point in using cognitive interventions? What do you say to this question?
Yeah. So you're talking about the exposure versus in vivo exposure therapy, for example, with and without cognitive therapy on top of it.
Mm-hmm.
Yeah. Well, it's funny because you see, sometimes that happens. Sometimes that happens, right? Where the exposure treatment works just as well, and there's no added benefit on that. I think that what happens in those cases, I think you get the happy sort of coincidence that people are sort of learning these things through the exposure therapy, themselves, right? That the bad things do not materialize, the sort of feared consequences if they were to do X, Y, Z, right? They do these exposures, and so they're extracting that from their own experience. That's wonderful, and I know that with Clark and his group, they did a very interesting paper in Lancet a few years ago. He originally drew the diagram on a napkin. We were having lunch once a few years ago, and now that's appeared in print. But it was actually sort of a meta-analysis kind of where they're looking at the different components. So this was social anxiety disorder, and then actually the cognitive elements were actually helping there, added benefits. So, but you don't always see that. That's true. I think that it really depends on what your time frame is in sort of treating that. So when you have people who have a lot of misinterpretations about rapid heartbeats or dizziness or going crazy and things like that, that sort of educational component, right, is, I think, quite useful to do. And so for the people who are afraid of doing the exposure therapy because they've got all these mistaken beliefs, it's often helpful to educate them. And that usually doesn't take that much time. Because I think that in some sense, the distinction, there was a lot of debate over the years between what is the mechanism, right? Well, when treatment does work, what the heck is mediating it? What's the mechanism of it? Is it cognitive? Is it dealing with beliefs and things like that? Or is it more just desensitized, extinction mechanisms? And I always think that those are, it's a distinction you can make, but I'm not so sure that that those things are all that separable necessarily. I mean, you can certainly do cognitive therapy without the exposure. I mean, Clark has done some work on this he and Sarkovskis with panic disorder patients, but getting rid of the exposure too also seems to be, I wouldn't do that either. What I've always done is have included both, quite frankly, because I'm sort of covering my bases in that case. Or people for whom the exposure alone is unlikely to correct some of the misinterpretations that are really quite cognitive. It's educational, actually. That's a little bit different from some of the more elaborate cognitive procedures where, like with cognitive therapy for depression, for example. By the way, that's another example where behavioral activation in the full bore cognitive therapy and cognitive therapy without the behavioral activation, which is kind of like exposure, where they all were equal. So yeah, sometimes you see exactly what the questioner said, that there was no value added. In other cases, you find the value added.
Richard.
Yes.
Can I butt in here?
Sure, yeah.
A bit prematurely, I must admit, but I was going to come back to this issue later. But since you raised David Clarke's work, this has been an issue. Remember that.
Metin, pardon. Metin, özür diliyorum. Biraz zor anlaşılıyor sesin. Sırf ben mi, herkes öyle mi bilemiyorum.
Yeah. Can you hear me okay now?
Better now.
It's a little better, yeah.
Yeah. I discussed this issue with both David and Paul many times. We used to work at the same place, as you know.
Yes, yeah.
And at some points, when they published our study, this was in the 1990s, Isaac Marks and I, and a couple of other colleagues published a critique, a letter in the British Journal of Psychiatry, basically arguing the point that there is no evidence from their study that what works in treatment is cognitive intervention and not anything else, not like behavioral experiments, for example. Furthermore, there is no study ever conducted in this field, as far as I know, to show that actually what happens during the session, cognitive behavioral session, is what works in treatment and not what happens between sessions. In other words, you can give any treatment you like to a person, and then off the person goes and next week comes back, and you never know what happened in the meantime. It could well be the case that cognitive intervention may translate into spontaneous self-instigated exposure between sessions, and that's what accounts for improvement when you see the patient the next time. Okay, there's no study designed in this way to show that it's not between what happens between sessions that accounts for improvement and not within sessions. I raised this point to them personally many times. And in the letter that we did to the British Journal of Psychiatry, they replied back saying, basically conceding the point that yes, there isn't an evidence and further work needs to be done to prove that it is cognitive intervention that is working or not. And some years later, they published a paper actually basically stating the same thing. There is no evidence. And the question becomes here, what's the point? What's this hullabaloo about cognitive behavioral treatment, you know? And cognitive behavioral treatment, it's like 10, 15 sessions, the full session.
Yeah, right.
They came up with a brief version of it, but still, there's a lot of things to do in a cognitive behavioral treatment session. Now, I'll come back to this issue when my turn comes, but I just wanted to raise the point that they personally consider this point.
Right.
There is no evidence.
Just to respond to your comment there. First of all, I completely agree with you that most of the real work is done outside the session. And I think that's what really distinguishes behavioral interventions in particular from, say, the psychodynamic ones, where the whole vehicle of change is the relationship between the therapist and the client, which had better be a good relationship, otherwise nothing's going to get done, right? But that's not the whole story, right? And so I think that, what one could say then is that the cognitive, the educational, and when I'm saying cognitive therapy, I'm also putting under there, the education, correction of misconceptions, things of that sort of a thing. That's the thing that I'm sort of emphasizing the most, which is sort of would fall under the cognitive rubric, certainly. But, if that sort of a process in the therapy then increases the likelihood of somebody taking the initiative and doing the sorts of things in the real world, then great. And so I think that's certainly worth doing. I mean, Albert Bandura once in his self-efficacy paper back in 1977, he said, well, one of the interesting paradoxes is that people are talking about, cognitive science and cognitive psychology and so forth. But it's really the best way of changing cognition is through experience, right? And through the behavioral activation, through the exposures and so forth. And so it's entirely possible that the cognitive fears, biases, diagnoses and what have you are important in maintaining the problem. And if what you do in therapy increases the likelihood of the person having sort of beneficial experiences out in the real world, doing, let's say, exposure or whatever, great. So that may very well be the case. I had, to give you a perfect example of that, we did an experiment. I said that psychotherapy research is not my main focus, but we did do this one experimental study in my lab with cognitive bias modification. Boy, I don't want to get too much into this. The idea here is that one of the correlates of people with anxiety disorders, or so goes theory at any event, it's a little more complicated, I think, than that. But they tend to, they focus in on threats. So someone with social anxiety disorder, they might enter a party and they're more prone to see expressions on people's faces that are looking, oh, this guy's a boring guy, or he's weird, I don't want to talk with him, right? And so they have a sort of a selectively attending to cues, interpersonal cues that might signal rejection or contempt or whatever, right? That's the idea, right? So, and so then they would get even more anxious, and they say then they flee the party, right? That's kind of the idea. And so Andrew Matthews, Colin MacLeod, and others, and Ada Amir, it suggests, well, gee, if a selectively attending to threat cues in one's environment that sets in motion this anxiety spiral, if we can correct that attentional bias for threat, maybe then we can sort of nip it in the bud. And so if someone is looking at people who look more friendly and cheerful, a attentional bias for people that seem friendly versus those that are standoffish or ignoring the socially phobic person, great. And so anyway, so there's this way of training attention, et cetera, et cetera, et cetera. So we did this, Alistair G., who's a reporter for The Economist magazine, he's based in Los Angeles, based in the United States, and he calls me up, and McLeod and all these others. So what are you guys doing, this cognitive bias modification? And he writes this cool article in The Economist. And in my lab, we just got flooded with people wanting to volunteer for the study. It was done remotely on the smartphones, right? So we did all these assessments. It was an experiment for social anxiety. And so we had these, and so then after the thing got publicized, and Ben Carey at the New York Times is doing this article on this and whatnot, and he wanted to speak to some of our subjects. It was an experiment, but they're socially anxious. It wasn't a formal treatment trial, it was an experiment. And so we interviewed some of these people, but we had to get their consent, and it's the whole rigmarole to do that. And so this one guy saying, oh, I was doing all the smartphone, I was using this high tech, changing my attention. And, and then I tell you, I feel so much better. Sure enough, we showed big effects in the treatment condition on social anxiety disorder measures. But we found just as big of effects in a placebo control where there was no training of attention to the positive and avoiding the negative, where it was even Steven, right? Versus a wait list. And so we found, and so, then these venture capitalists are contacted. I says, oh, we go. I said, well, time out. We can't do that. Whatever this is doing, it's not changing their attention. Yes, they're getting better. Yeah, come to our lab. You'll get better. But what seemed to be going on is that these guys were doing the placebo thing with the faces on their cell phones, and they're attending and doing this, that retrains their attention, supposedly, this high-tech intervention. And then what they did, they felt more emboldened in virtue of this sort of manipulation to go out to parties. They felt more confident. The interactions were positive. The social anxiety went down. This is exactly the parallel, I think, with the case when you're talking about with David and Paul, Sarkovskis and Clark, about what does cognitive therapy do? Well, this is what happened here. It wasn't cognitive therapy. It was a cognitive science intervention that really, it worked in the placebo condition as much as it did in the official one. Why? People went out, they felt emboldened by this to go out into the real world, and they got desensitized. So there you go. So I think that, yeah.
Oh, I just thought you finished because somebody just raised hand, and I want to give the chance to him. So I'm sorry.
Sure. Yeah.
Richard, this is Mehmet. They want your colleague. You exchange mail
good
with.
To see you.
Nice to see you, Rich, as well.
Yeah.
Thanks for your brilliant talk. This debate, cognitive versus behavioral has been a long-standing debate, and it's a very old debate, as you can remember. Nowadays, all of these terms are losing its specificity. Even the term CBT is losing its specificity, and nowadays it's used as an umbrella term that includes many empirically supported approaches, including the third waves. So when you say CBT, actually people don't know what you're referring to anymore. So this term has been enlarged. It's not the same as if it was used in the past. And it's a discipline, a CBT, I think, with a very flexible but empirically grounded theoretical basis that allows transfer of new developments in it. Because as you can imagine, given time, every theory proves to be wrong. You know, when you give time, everything proves to be wrong. So obviously this whole debate depends on behavior versus cognitive stuff is not valid anymore. CBT is made a marriage, and they're very happy with that marriage. Let me first tell you this, as being the president of many international associations regarding CBT. And I think the debate that Metin brings works the same for behavior therapy as well. You know, behavior therapy or cognitive therapy is not a therapy made to the patient, but it's made with the patient. So obviously what the patient does brings the outcome, or whatever he doesn't do worsens the outcome. So let me ask this question because the audience probably does not know what the difference. Some of them are not in the psychology field, so they don't know what is behavioral and what is cognitive. Let me say, to make it more understandable to them, when you refer to exposure therapy, you're referring to behavior therapy. When you refer to correcting misconceptions, then you're referring to cognitive therapy. But then my question becomes, even when you are talking about exposure therapy, when you think about it, we need to know the processes. You know, it is the processes that make something work. Is exposure really based on habituation or tolerating distress, and therefore it is behavioral? Or another question, is exposure work through corrective learning, disconfirming the expectancy or the hypothesis, as you say, and therefore it is cognitive? Or is exposure embracing emotion and therefore acceptance-based? You know, this is the main question. So we need to know the processes that make the therapy work. And obviously exposure has every element in it. Exposure has the element of distress tolerance. It has the evidence of habituation. It has the component of corrective learning, because what you make by exposure therapy is something you learn. So that makes cognitive processes change. So when you do exposure, actually you learn the outcome. So you actually test the hypothesis, as you wonderfully put it. And what you find out that it doesn't work that way. Like if you put patient into a situation where he exposes himself to the agoraphobic situation or the panic situation, and they fear that they're going to die, and they find out that they don't die. So is that behavioral or is that cognitive? Because they're learning something new. So in that sense, every behavioral experiment has some cognitive elements in it. Obviously, you're exposing yourself to negative emotions. I don't believe in negative emotions, by the way. Every emotion is an information. Everything tells us something new. But obviously, even if you name it negative emotions, we all learn from emotions, because emotions is knowledge. So in that sense, by making exposure therapy, you are embracing the emotion, as you said in mindfulness, you stay with that emotion, yeah? So you embrace the emotion, therefore it is working through acceptance of that emotions. So obviously when you don't know about these mechanisms, there's no way to actually say that behavior therapy works better than or same as cognitive therapy. This one is better than this. I think we have to find out different horses for different coaches. And even if you apply cognitive and behavior therapy, and some people make use of behavior therapy and some people make use of cognitive elements more, it doesn't matter. It is not the competition. It is whether we are helpful to those people or not. That is the main question. That's what I think. Thank you.
Mehmet, I think what you're saying also draws a very important distinction. There's two different issues here. One is what the therapist does, right? You know, so what's in the manual? What is the person actually doing, right? So, for example, do you include cognitive correction? Do you include interoceptive exposure, for example, in there or not? So there's something that you're actually doing. As you pointed out, it's really you can do whatever you can do all kinds of different things, but it's the patient who's going to have to initiate this and do it, and who's actually the locus of change, right? But if you just look at it in terms of the procedural issue, you can certainly do exposure therapy without cognitive therapy, cognitive correction, or even the educational components, other than simply saying that, you know, by practicing encountering things that are not dangerous, but that frighten you, that exposure to those sorts of things will diminish your likelihood of, in fact, continuing to fear them. It's going to reduce your sensitivity to the situation that provokes fear today. Just a very minimal instruction, then doing exposure therapy, either therapist assisted or self-directed. And someone can either include or not include the educational components about, fainting and heart attacks and all that jazz, the alternative explanations for the symptoms that puzzle and frighten them, and panic, for example. So there's the procedural difference, whether or not empirically, you know, that's the case. And then, as you point out, is that apart from what you're doing, the actual mechanisms in the person could be operating on a lot of different levels. And
Exactly.
so doing exposure therapy, someone says, aha, you know, I keep doing this and I don't faint, and well, I guess I had that one wrong, right? And so you can.
That's what exactly I'm saying. Whatever you do is what you think you are doing, but what the person or the patient is taking out of it is something different. Sometimes you do something totally behavioral, but it has implications of cognitive change for that person. So it is the perception, and it is not the elements that you put in is behavioral, but the come out is actually the result is also a cognitive change as well.
Yeah, so, but the point here, Mehmet, is I agree with Richard here. The point is it's important to make a distinction between procedural issues from mechanisms of change issues.
Yeah.
What do you need to do in treatments is one issue, separate from what happens in treatments intentionally or unintentionally is a completely different issue. Here
exactly,
we are talking
but then
about
we are also
procedural issues.
But let me tell you that,
and we're gonna be talking more about mechanisms of action issues when my turn comes.
Okay, mechanism of actions is definitely different, but we are talking about outcome, because the problem or the issue that you brought up is what is the difference if behavior therapy is as good as cognitive therapy? Whoever asked that question, what is the point of doing it? The point is, it is the change, it's the result, it's the outcome that we take. So processes of changing, of course, is different, but the outcome, is it
always different? We don't know if it's different. Evidence shows that it is not different.
That's what I'm saying. So what is the point in bringing up, what is the point? If they're not different, that means we have two alternatives. If it's, so we need cognitive therapy. Some people will choose cognitive therapy, others will choose behavior therapy. If it is the same, there is no. If it is the same, there is no time consumption. I'll just leave the discussion. But what I'm saying, if they're equal, or if there is no difference, that means you're giving two options to the client rather than one. That's an advantage. Two is bigger than one. You give them two alternatives instead of one. So that's the idea what I'm bringing in. But let me pull back in here.
Anyway, I'll wait for my turn to address these issues. Let's not waste Richard's time.
Richard, shall we, Richard, how long time have you got, you think? Or shall we give a break now, like a 2-minute break? Well, or actually, you want to go on and finish your slides?
Well, actually, I think the discussion we're having here is very interesting in its own right.
Right, exactly.
And so...
or fact, you would like to go on the discussion, whichever. It's your choice.
Yeah, Metin and I were joking about this a couple of months ago when we were first talking about this. This is the most fun part, right? To get in, and we got Metin joining us as well. I didn't know he was going to be here until just the other day. But I would like to just add another example about this. Is if we're distinguishing between process or procedure, what the therapist does, what the therapist spends time doing, over the course of treatment. Between procedure and then mechanism and then outcome, right? So if we look, we see that these are really quite different, right? So what does the therapist have to do to initiate some process, whatever that might be, that results in a beneficial outcome for the patient. Right. So those are, I think, all three different things. So I think we all agree on that. And just to give an example of this, of where Metin's point about efficiency or the time issue, what was really important. When I was trained, I did my clinical internship and postdoc at the behavior therapy unit at Temple University in psychiatry under Joseph Wolpe and Edna Foa. They were my two supervisors. And Wolpe, he was systematic desensitization, right? And Joe Wolpe's methods, he was a revolutionary in many ways, really got the whole field going. And evidence-based psychotherapy in many ways comes from the fact that he did systematic desensitization. He could specify the procedure really well so you could teach it to other people and test its efficacy and do what is called a dismantling treatment. So, because Wolpe would have people, you have them relaxing, and you have to go through this profound muscle relaxation, and then you would then have them generate an imagery, a whole hierarchy of progressively threatening situations, say for a social phobic, starting out with some mildly frightening things, then on to asking somebody for a date or whatever it happened to be. Now, and so, but before you could do that exposure to these images, and then if they got too anxious, they would stop the image, etc. If they get desensitized to all this imagery, and then they would do things in the real world, carrying out these exercises. So first they go through the deep relaxation, then they do the imaginal desensitization, and then finally they get around to the in vivo, real life assignments out in the real world, where they encounter and practice progressively frightening activities until their anxiety diminishes. Now, what it turned out, so then they do these dismantling studies as well. You can do systematic desensitization, but throw out the relaxation component. Or you can do maybe just go straight to the in vivo exposure rather than doing the desensitization and imagination first. It's like we're treating the patient with kid gloves going along. And so there's actually studies that showed that in most cases, the imaginal desensitization didn't really have value added versus merely doing the in vivo real life desensitization exercises, and let alone the whole business about relaxing the patients. Boy, that was a laborious procedure, unnecessary. And so then what happened, then you start getting these more streamlined interventions. Metin referred to one of his, I guess, one of your mentors or senior colleagues, Isaac Marks, University of London psychiatrist, Institute of Psychiatry there, who really, he just said, let's just do what works. Let's stick with the in vivo exposure. The bells and whistles, the imaginal exposure, the progressive deep muscle relaxation does not have value added. So there was a distinction there, right? And so these are important. So today we don't typically do the deep muscle relaxation or the imaginal desensitization, except for in very few limited cases. So this, all of these things are, so I think it's good to keep that in mind, you know, what is the person doing, the procedure? Then there's the issue about theoretical speculation about mechanism, and then finally the outcome. And I think, you know, Metin, you were referring to the outcome was not differential. So implying that there was no value added, for example, to cognitive therapy, just like there wasn't, say, with relaxation to desensitization.
Richard, are you giving a break, or are you going on? Are you going to continue till you finish with the slides?
Well, should we take a break now? Give people the listeners.
Why don't we then? 2 minutes on. 2 minutes only, Richard.
2 minutes only. Okay. Wow.
Okay. Okay.
Okay.
I think everybody is back.
Exactly, that's correct. I mean, the time is up anyway.
Okay. Okay. Okay. I could give a couple more examples of some of the other treatments here. And then I guess we'll hand it over to Metin for the discussion, right? And then open the floor up. I'm wondering how much time we have here.
No limit.
No limit. Okay.
To the morning.
Or rather, sky is the limit. Or tomorrow morning is the limit.
All night.
Pull an all-night discussion. Actually, I've got another Zoom session to do. As I mentioned, I did one with the Dutch in the morning, and I got that with the New Yorkers now here later. So
Cancel the New Yorkers.
They're a little bit later, right? A little bit later. Okay. What I'll do here is just go through a couple other examples here of this with social anxiety disorder, social phobia. I'll move through this fairly quickly here, but this is a marked and persistent fear of social situations. That really is about doing things that may expose you to humiliation, embarrassment, et cetera, et cetera. A lot of times people are afraid that they are either going to be rejected by others, or they'll actually show anxiety symptoms, and then people will see that, and that'll be upsetting. These situations almost always provoke fear and anxiety, and people try to avoid them as much as they can or endure them with intense anxiety. So with a lot of phobias, such as, say, fear of flying in airplanes, if you're afraid of flying in an airplane because you think it might crash, you can always take the train, for example. But with social phobia, it's a little bit harder because unless you're going to be a hermit, you're always going to be interacting with other people. So it's in many ways is more problematic and more likely to interfere with your life. And so once again, the fear is out of proportion to the real threat, et cetera, and it's persistent. Okay, so these, a lot of times it's just simply the person is afraid of showing signs of anxiety, blushing, trembling, sweating, speech disfluencies, vomiting. I had a patient once who, before going into a social situation, she would actually induce vomiting if she had to go outside in a social context. And she was not a bulimic or anything of that sort. It was just that she didn't want to get so anxious in a public situation that she would throw up on other people, because that would be very embarrassing and unpleasant for the target of that vomit, so to speak. Being observed in public, in performance situations, public speaking. Fear of speaking in public is the most common social fear, but it is usually not that impairing, because most people, unless you're a teacher or a minister or etc., you don't have to speak in public very often. Arriving for class, performing music. This is another common one. Eating in front of others, drinking in front of others, writing in front of others. I had a patient once who was a junior high school teacher who had a fear of his hand trembling when he's writing on the blackboard. He thought the kids would mock him. Or people who, for example, have a fear of their hands shaking when they are writing a check, or more commonly, signing the receipt for a credit card use, right? And so you think, oh my goodness, a person can't use a credit card because they're afraid of signing the slip in the presence of someone else. Using public restrooms, a fear that you will be standing in front of a urinal. You'll be so anxious you won't be able to urinate, and then people come in and start laughing at you, and et cetera, et cetera, et cetera. So social interaction fears, initiating conversations, maintaining them, meeting new people, dating, talking to strangers, sexual situations, going to parties, returning items to a store and said, well, this is broken or it doesn't fit, etc. Expressing disagreement. Talking to authority figures on the phone, inviting friends over for dinner. When you see the sort of the foci, the focus of social anxiety fears, they are indeed quite pervasive. It's a little wonder that folks who've got a fear of this interacting with other human beings for fear of being embarrassed or rejected, humiliated, have a challenging situation on their hand. So the CBT folks the behavioral strategies, role playing. These therapies can be done one-on-one with a client, but a lot of times, especially in centers that focus in on, say, treating social anxiety disorder, social phobia, we can use those interchangeably here. The terms are essentially the same. Often treat people in groups, right? And so you're interacting with other folks who are struggling with the same issues. And so then you get a chance to where the therapist will model some behavior, asking someone up for a date, discussing one's salary with the boss, you name it. And so then they'll model this, and then the patients will do behavioral rehearsal. Then there's the in vivo exposure situations. And so talking with sale clerks, you may have the person going to an assignment to go to a shopping mall and interacting with different clerks at each of the stores, et cetera, et cetera. These sorts of things. Imaginal exposure in some cases can be useful. Where you're imagining, for example, I had one patient who had the fear of urinating in public toilets. That was his only fear, and he had all these scenarios that he'd be standing there at the urinal, and all these guys would come in, and people say, "Hey, look at this guy here. Hey, what's wrong, buddy? Is it broken?" Laughing like this. This is what he was afraid was going to happen. And of course, eventually, so you're doing these sort of dramatic things, in the imaginal exposure. He's getting distressed, but eventually habituates, etc. And the situation seems as absurd as it is. Cognitive restructuring, again, testing the catastrophic hypothesis. So what would happen, for example, if you were standing in line and you're going to make a purchase and you're going to pay in cash, and then you drop the money on the floor, and the coins are bouncing on the floor, and you've got these impatient customers right behind you, et cetera, et cetera. What do you think would happen? Because, oh my God, I'd be mortified. I'd be shaking. My hands would be shaking. I'd be so embarrassed if I were to just drop the coins on the floor and have to bend over and pick them up and hand them to the register. I'd be blushing. It'd be terrible. People start laughing at me. Or, for example, suppose I sign the credit card and my hands start shaking. What do you think might happen? Well, the person might start looking at me and snickering and say, "What's wrong with you? Got something wrong with you? Why is your hand shaking?" Okay, these are all catastrophic hypotheses. So the exposure therapy would have them doing these sorts of things, mindful of the sort of predictions they've made on what might happen. So to actually deliberately do something like this that should provoke this reaction. And of course, most people don't care. What happens? They drop the coins and people sort of help. So, "Oh, that's okay, let me help." And they help the person. They don't laugh at them, right? And so sort of the prediction, and here's the cognitive element of this. So when Mehmet was talking about both of these things sometimes get involved. Now, of course, you can structure the exposure situation with explicit mind it's going to test the prediction that they have, like a scientist running an experiment, or you can just have them do the exposure, right? So basically, there's two things going on. One is that you're testing the probability that the bad thing would happen, but also the other one, the valence. How bad would it be if some stranger who gets impatient when you drop the coins is going, "Oh," he's getting exasperated. Is that the end of the world? 5 years from now, will you still be worrying about that? No, of course not. So the socially anxious person usually has an elevated probability estimate, so to speak, of the likelihood of something bad happening, and also the negative valence, the badness of it, tends to be rather inflated. "Oh, I'd be mortified. I think I would die with embarrassment." Die from embarrassment? Well, let's see. Okay, so then the exposure would involve actually doing some of these things. Okay, and so in this particular study by the Rick Heinberg group and Mike Leibowitz, they gave them phenelzine, an MAO inhibitor. It's originally an antidepressant, but it comes with a lot of restrictions and some side effects. But the cognitive behavioral group therapy versus the phenelzine. So both of them are very similar effects at the end of treatment. Then there was a group that was a pill placebo group. Some people responded to that. At least the percent classified as responders. And then also an educational supportive psychotherapy group. And so in other words, so this is sort of a supportive group where people are talking about their issues and problems about social anxiety and avoidance and fear and the like. but they weren't actually doing the behavioral exercises, the modeling, the behavioral rehearsal, practicing these different things, which is also involved with exposure therapy, but it's also practicing skills, right? So it's not just simply an extinction mechanism, so to speak, alone, but the person is learning new skills, what to say, what to do, and they're practicing these things, and then they're doing them in the real world as well. At the follow-up, though, when we're talking about people relapsing, you found out actually that once people went off the phenelzine, this is a problem we've seen a bunch of times when the person is not on the medication. There's a tendency for relapse to occur in what these behavior therapy types are saying here. Cognitive behavior therapy folks are saying that really, that if you're doing a treatment that does not necessarily involve the development of these skills, mastering your fear and confronting these situations, doing things differently, et cetera, in a way that changes your thoughts and feelings, then you're likely to relapse if you remove the medication that has helped manage the symptoms, kind of put a lid on them. The anxiety symptoms, you're a little more prone to relapse if there hasn't been active learning on that. And of course, someone might be learning these things on the medication, in which case then you're going to probably be okay. But there's some cases in where there has been combination things that have worked here with phenelzine, pill placebo. This is another big study that was done here where the combined treatment looked quite, quite good as well. Obsessive compulsive disorder is another one. This is probably the condition this is no longer an anxiety disorder according to the DSM-5, but many of us who work with these patients have always sort of considered fear and anxiety to be really quite central to this, and avoidance behavior and et cetera. Obsessions are recurrent thoughts that are intrusive, images, impulses, et cetera, that produce distress. And the compulsions are something that the person does to manage or reduce the anxiety, the distress associated with the obsessions. The compulsive rituals, hand washing if you have obsessions that you might be contaminated, checking or rechecking when you have obsessional doubt that you're not sure whether you locked the stove or locked the door, or turned off the stove, locked the door, et cetera, et cetera. So the compulsions reduce anxiety usually in the short term, but in the long term, they render the person especially sensitive, and you get sort of a vicious cycle going on here until the person can be quite impaired. The repetitive compulsions, hand washing, ordering, rearranging things so they're just so. Some compulsions are cognitive, mental acts like praying or counting or repeating words silently to oneself to sort of counteract the effect of the obsessions, etc. So just to sort of move along here a little bit quicker. So the compulsions then reduce anxiety, they reduce disgust, and they tend to prevent feared disasters. So a person may have some image of their house burning down if they don't check and recheck all of the electrical equipment to make sure it's not plugged in and running, etc. Sometimes the person is they feel uncomfortable when things are not just right or just complete. It's a feeling of things have to be absolutely symmetrical and just right. So they may feel when they're walking through a doorway, they have to walk in such a way that their left foot hits the ground at the same force with their right foot, and have to do it over and over again until it's just right. And so some of this stuff seems quite nonsensical, but the person typically knows that. Sort of the standard treatment has been in vivo real life exposure plus response prevention. So here we go again with another procedural sort of distinction, whereby people are encountering things that are progressively harmless, but progressively threatening to them. So they have a hierarchy of things that are quote unquote contaminated, touching the floor, touching trash cans, touching urine, whatever it happens to be, so forth, and then not washing afterwards. So if we're thinking about contamination, obsessions, washing, compulsions, that's an easy model to think about. So the person's doing exposure as if they were sort of a phobic patient, say a fear of heights, going up higher and higher on an outdoor fire escape and looking down. And now here you're touching things and handling them that are not objectively dangerous, but are provocative of a lot of distress and fear and anxiety. Now, the response prevention is not doing the ritualizing right after. And so here we get a little bit of a procedural distinction here. So, for example, Edna Foa and Gail Steketty some many years ago did a study where they randomized OCD patients to either to do the exposure therapy, but without the response prevention, right? So they would do all the exposure therapy, and if they wanted to wash or whatever afterwards, they could do that. Then there was another where they just did the response prevention, right? So they no washing and then finally the combination, and the combination really did work the best. This was pretty clear. So, for example, a person might do touch all the contaminants, quote unquote, and if they washed right after, they wouldn't get the chance to see the anxiety go down, right? And if they couldn't wash, then they just avoid touching things in the first place. But if they did both, they had the best benefits from that. And so, Luana Marcus is a colleague of mine in psychiatry at Harvard. This is a diagram of Luana's. I mean, this is a very standard one, but exposure and so forth. So the person, they might have some anxiety, and then suddenly they do their washing, and it'll reduce their anxiety. But the next time, this is sort of a idealized schematic. And so, but they might get more anxious. They got to wash a little bit longer, but that still eventually works. But that renders them more susceptible. So now the more they tend to avoid, the more sensitive they are to the provocative cues. And so now they got to wash or ritualize even more. So, I mean, I think the world record for any patient I treated was a guy who right before treatment had washed and showered for 14 straight hours. Before embarking upon behavior therapy, exposure and response prevention for OCD. Now, the idea here, though, is, so here's the avoidance thing, right? So the person, so it can short circuit the habituation or the reduction in distress. And so if the person does not wash, eventually the distress will eventually go down. And so you have, this is the sort of within session habituation is what it was called, was that when there's no real danger here, you've touched, you're the bottom of your shoes and you've roughed it, washed it all, put your hands all over your face, and you're really, oh my God, I've got germs on me, da, da, da. But nothing happens, and eventually the distress diminishes, right? And so then the next time you do it, you may also have some anxiety, but it doesn't reach quite the same peak. And so it's going down. The peak anxiety over sessions show between session habituation. So not only does your distress go down when you don't wash, but you're not hitting as many peaks. So eventually towards the end of treatment, you may do this and it's very little distress and it goes down, et cetera, et cetera. This is sort of this process. Now, there's been a lot of debate about whether or not within session habituation is essential for between session. Michelle Krask and others have found some evidence that even if somebody doesn't completely decline within the session, they still can improve some. But these are some of the standard ways of going about doing this. And another one of these collaborative studies done by Edna Foa and Mike Leibowitz. Mike is, he's now retired now, but was a psychopharmacologist, and Edna, a behavior therapist. And they did intensive in vivo exposure plus the response prevention and clomipramine, another medication, tricyclic antidepressant, as it was called, which was effective in treating OCD. And then also the combination and a pill placebo. And they found out that so here we're once again, unfortunately, these are examples of behavior therapy versus a drug versus, say, a cognitive therapy or whatever, but had twice the effect size as clomipramine did in terms of reducing obsessions and compulsions. And so basically the behavior therapy was equivalent to the combination, which is better than the drug, which is better than the pill placebo. So here you sort of see what they found here is that the intensive exposure and response prevention, this is actually treating people for a couple hours a day, 5 days a week for 3 weeks, and then with some follow-up. So it is quite intensive, and there's homework. So it's not just having the therapist guiding you through touching things that are contaminated and then etc. But doing practice sessions on your own, and then washing every 5 days, showering every 5 days. So it's an intensive treatment, and not everybody is keen to embark upon it. But if they do, you sort of see this really dramatic drop. The Y box is a measure of OCD symptoms. So this is quite an impressive drop. And whether you had the behavior therapy alone or the medication, well, it didn't really matter. The medication also worked, and the pill placebo, very, very little. You don't get that much of a placebo effect in OCD for whatever reason. So it was clearly, it was, again, the behavioral treatment was really quite good in this case here. Okay, so these are some of my examples here that I wanted to show. I probably should have chosen some that were different psychotherapies against one another, I guess, given some of the questions that we've had. But I just want to open it up. I guess, Metin, are you going to comment now? Because I know you've got a presentation here to do too, but I'll let that to Özlem here. I'm acting like I'm the teacher. I'm actually,
yeah.
That's what happens. You teach like this all the time, and oh boy.
Yeah, we have two questions, but I'm going to ask them after Dr. Başoğlu presents his presentation. Actually, I want to make something right because I mispronounced where he was conducting his trauma studies in. I said Cambridge, but instead I should have said that King's College London. So I'm sorry about that. Now I think we can hear Dr. Başoğlu's presentation right now.
Yeah, there are two King's colleges, right? Two of them. Yeah.
Richard, you need to stop share screen.
Yep. All right.
Okay,
there we go.
Thank you.
All right.
Özlem, can I suggest that we take the two questions first and then I go in so that they don't have to wait for the whole thing for me to finish? Is that okay with you? If the audience has questions, we can take them. You said two questions.
Yeah.
Before my presentation.
Okay, that's fine, but
hadi Özlem al artık uzatmadan, ne olur. Metin de razı oldu. Al başta Şeyda sorulardan.
Okay. One of the questions is, what's the longest and most dedicated part in DSM?
Özlem, just one moment again. You need to give the name of the person that's asking the question, and there was a question before his. I think it was Refix.
Yeah. Okay. Okay. Then let's ask the other question. Refik Kutluer is asking this question, and it is: as placebo shows the power of the uncontrolled brain, can you measure the effect of this power in medication treatment? And if you can do so, may this lead to preferring fake medication to real ones? Says the question.
Okay. Okay. I'm not sure if let me see if I caught that right. So it was a question about the power of the medication versus the pill placebo.
Yeah. Actually, I mean, the question is talking about if placebo works as well as the other medication, then is it possible to use fake medication instead of real ones?
Oh, yes. Oh, I see what you're saying. Yeah. Well, that's not always the case. Not always the case. I mean, and most in some of those cases, well, in the OCD case, when you added clomipramine to behavior therapy and then you added pill placebo to behavior therapy, I mean, you know, that's not making any difference, right? But there's a difference between the drug clomipramine and the pill placebo. Clomipramine was clearly better than the pill placebo. But there are cases in which there isn't a difference. And so then you get this very interesting question about pill placebos. There's this one guy over at our medical school. I don't know him personally. Ted Kopchik, I think is how he pronounces his name. And he's done some studies with, not with our patients, the OCD patients, but where he would give people the sugar pill and say, this produces the placebo effect. It doesn't have any pharmacologic, but it produces the placebo effect. And supposedly he actually gets an effect even when you say that. And so I guess if you're dealing with any medication that's sort of involving this, the brain, the central nervous system, blah, blah, blah, I mean, there is a placebo. If it's whether it's the same effect, that's a whole other controversy in its own right. Whether when you get placebo effects, what's the mechanism of that? What's going on, right? That's a good question. I mean, statistically, you will see studies where there's a weightless control and a pill placebo, and then an active drug or some other therapy, and you'll see differences between oftentimes the pill placebo and the wait list, which means there's something going on there. Because the wait list just measures whether or not people are changing instead of getting better spontaneously over time for whatever reason. And if they're not doing as well as that sugar pill group, something's going on with the pill placebo. In fact, one of the interesting things is that you can also have a pill placebo, which, by the way, is not very much liked by the pharmaceutical industry. It's a pill placebo. The only thing it does is give you some side effects. You might get dry mouth, or you get orthostatic hypotension. When you stand up quickly, you feel a little dizzy. And so it has the side effects of a real drug, but doesn't have the alleged therapeutic effects. And that is really a challenging thing, because some people say that when you start taking the drug, you get the side effects sometimes initially, and then that remoralizes you and you start doing things again, and for whatever reason you get better, but whether it's pharmacologic or not is sometimes unclear. But in any event, so the pill placebo thing is really interesting. But I think Kapchuk is the only person I know who's actually given people placebos and told them that. And you're going to get because otherwise there's the ethical issues, right? But that's a great question.
Sinem, sesin kısık. Özlem, pardon, sesin kısık. Bir dakika Özlem, ben bir devreye gireyim. Sinem, would you like to ask your question yourself? I mean,
I asked her and...
Bir dakika Özlem. Unmute yourself, Sinem. Okay, you ask your question yourself.
Yes, I asked, hello, thank you for the presentation, first of all. I asked, what is the longest and most dedicated part of DSM? You talked about DSM, maybe most of the audiences doesn't know.
Oh, yeah. The Diagnostic and Statistical Manual of Mental Disorders, 5th edition. Boy, that's the longest. That's why they call it DSM. It's got too many letters in it, too many words. What that is, has different sections. It has sections on psychotic disorders. And I'm not sure exactly which is the longest one, because what it does, it has the different disorders described, and then the criteria listed, and then the accompanying text. So it's just what is the
alkol ve madde kullanım bozuklukları.
Sorry? Oh yeah. And so I'm not sure which is the largest section. I think the anxiety disorders is a very big one. The mood disorders is quite large. Then you've got others. You have the sexual dysfunction section, and then the paraphilias, you have childhood disorders. I mean, they're all fairly big, and the ones that contribute to the largest sections, mood disorders, anxiety disorders, are also those where you've got a lot of different syndromes falling under that rubric, and also a fair amount of accompanying information along with it. So, they'll be asking about things like risk factors and things of that sort, associated features. There's a lot of knowledge about that. And so I was on the DSM-4 committee that came out in 1994, and then it was a revision 6 years later, and almost the entire revision of the manual was just all the accumulated information. The diagnostic criteria almost never changed. The actual criteria for diagnosing the signs and symptoms of the syndromes, but it was all the other stuff that had ballooned as well.
Okay, I will just first answer the question in Turkish. DSM'deki yani biz psikoloji ve psikiyatride tanı için kullanılan kitaptaki en uzun chapter başka türlü adlandırılamayan bozukluklar denilen chapter. Non-otherwise specified chapter is the longest one.
Yani nasıl bu şimdi soru mu değil mi anlamadım.
Sorunun cevabını da verdim.
Ha verdim peki güzelim tamam.
Ben bir şeye girebilir miyim çünkü soru yanlış anlaşıldı Sinem.
Evet,
Senin
evet,
sorduğun
de,
soru en çok zaman alan değil. En sık tanı koyulan bozukluk ne demek istiyorsun değil mi?
Hayır,
en sık koyulan
DSM'in en yani uzun bölümü en
uzunluğu bilmiyorum ama en sık koyulan tanı konulan grup dersen not otherwise specified.
Evet.
I thought that her question is related to what is the most frequent diagnosis made in DSM, and that is not otherwise specified. That's what she's, I guess.
Yeah, that was that was it was certainly the case with the DSM-4 and the eating disorders, for example. If you just look at the eating disorders, anorexia nervosa, bulimia nervosa, then you got eating disorders, NOS, not otherwise specified. That was the most common one, mainly because you had people who had symptoms of all of the others, but not the full criteria for anorexia or the full criteria for bulimia nervosa. But I think that in terms of overall, the most frequent ones that are diagnosed out there in the real world is certainly with anxiety disorders and mood disorders, especially depression. And like the World Health Organization and these big epidemiology studies around the globe, look at the burden of disease, as those guys call it. You got a big section of that is covered by anxiety disorders and mood disorders. And then it drops off quite a bit, say with schizophrenia. Much less frequent, a little under 1% or so.
Yeah. Actually, if we look at the pages that has the most length, then we find out that alcohol and substance abuse is the most longest part, we can say.
That's right. Oh yeah, that's right. And if you were, I've done some work in epidemiology as a clinician out in the field, track and the National Vietnam Veterans Adjustment Study in the 80s, and we had to cover everything, right? And the substance abuse out there in Chicago, where I lived at the time. You have to go through all of the, you got amphetamines and cocaine and marijuana, alcohol, heroin, and oh my God. And then we finally get to the other PTSD, oh my. A lot of ways to get high, that's for sure.
Exactly. I think there are two more questions. There are two people who raised their hands. And Haluk Yılmaz Türk is the first. You can go for it and ask the question.
First of all, thank you very much for your time. A lot of good information here from the clinical perspective. And I may be jumping the gun, and I don't want to take this conversation off track here, but I was interested in the technology side of things, see how you collect the data and analyze data and make it meaningful. And the reason I'm asking for that is I'm a co-founder of a company that deals with patient-reported outcomes and evidence-based treatment algorithms for chronic diseases. We have about 8 applications live right now, starting with rheumatoid arthritis, chronic pain, cardiology, and also adolescent mental and sexual resiliency. And we do have a grant from University of Northern Colorado. We work with Professor Lisa Rue. I'm not sure you may be familiar with, but that if you're going to talk about that, I have to sign off soon. So I just wanted to see if that's something you're going to touch on. If not, I'd like to reach out to you and Metin abi, see if you would have a moment to take a look at what we do and get your feedback on it.
Yeah, in terms of the technology, usually now it's mainly smartphones and very wearable devices and things of that sort. we've done some of that more in the assessment, dealing with sleep disturbances and dealing with PTSD symptoms and also bipolar disorder, where people get pinged on their smartphones and then are being assessed with, slider scales and mood ratings and things of that sort. Now, those are assessment sorts of procedures, right? Yeah, as opposed to treatment. Now, there have been attempts to devise very scalable interventions that involve using computers, all right, laptops on the internet, for example, Jessica Schleider was one of our recent PhD students of John Weiss's, and she's now assistant professor at Stony Brook in State University of New York. And Jessica has been working with adolescents who are showing signs of anxiety and depression, right? When we get that age 14 period where you get a lot of these conditions are sort of materializing. And this is based, it's a 1 or 2 session, 2 hours at a program. It's dealing with some of the Carol Dweck's work on mindsets, right? So I don't know if she's a social psychologist, says people have either fixed or growth mindsets, and she was originally working with intelligence. Is intelligence something that you're born with, or is it simply a marker of a lot of skills that you're developing that are dynamic and subject to change and improvement? Now, she sort of applied that to things like shyness and anxiety, et cetera, et cetera. And so she's been studying this sort of a thing, which is all can be done remotely with kids at risk for anxiety and depression. And this is very much, we're talking about the cognitive procedures and so forth versus behavioral. This is definitely sort of a cognitive one, trying to have kids think about themselves, their attributes like shyness or proclivity to become depressed or withdrawn, and seeing this as something that is not fixed by their genes or otherwise unchangeable, but rather it's embodies sort of a lot of skills, and people can learn to improve it. Like the brain can change; it's like a muscle in some regards, and so it's got all these metaphors and the like. And so that's one example of using a big scalable intervention that's very cost effective, using the technology, in this case the internet and laptops and the like, to reach a lot of kids. And so it's fingers crossed how efficacious that would be, because it's certainly very efficient, right? It doesn't take up that much time. And so we'll see. That's one example of that. The one that I had mentioned earlier when I was talking about the placebo intervention worked just as well as the other on changing attentional biases. That was also in the spirit of using that. We had hundreds of subjects involved in the study. We had them from Switzerland, Canada, the USA, because it was very easy to do and very actionable. The good news is that people got better versus the wait list. The bad news is that the people in the placebo technology intervention did just as well as the theoretically therapeutic one. So apparently, because like Metin was saying, it got them initiating exposure in the real world. But so it's still quite, so I would say that the technology, the assessment of emotional states and symptoms is more advanced by technology than has the treatment interventions themselves. So I think that the treatment's sort of a little bit behind, I think, the measurement of symptoms and assessment. But that's clearly an important goal for the future.
One thing, one part of work that might be relevant to your question.
Metin, can't hear you very well.
Okay. One part of work that you might find relevant to your question, Haluk Bey, is that we've developed a self-help manual for earthquake survivors. After the 1999 earthquakes in Turkey, and I'm going to talk more about the treatment that we developed. And it's a highly structured manual, about 50 pages. And at the time, we had in mind computerizing this program. This manual involves a full assessment of the person's psychological status, PTSD and depression symptoms, and suitability for treatment. And then once the patient is found suitable for treatment, then the treatment begins, and it's a self-administered treatment from beginning to the end. and their regular outcome evaluations. And there's everything that's needed for treatment to be delivered without the assistance of a therapist. It's an ideal sort of source that can be computerized and made available over the internet. I had always in mind to computerize that manual, but never had a chance to do so. If that's of any interest to you, then we can talk.
It is. I mean, what we do is we just do the assessments. I mean, we integrated like.
Haluk, let us stop now. We're not. You can talk about your what you do later, but I shared Metin's document with the group, which you ought to have received yesterday. So, and then let's move on to Cengiz. Özlem, can you continue with Cengiz Kılıç and his question?
Okay. I think he can ask his question.
Okay, thank you. Hi again, Rich. Thank you for this.
Good to see you.
Yeah, same here. And thank you for this a nice summary of all the evidence-based psychotherapies. I mean, my question is comes very late, but I was expecting to hear about non-evidence-based psychotherapies a bit, at least, because you know what? I mean, it's a very nice coincidence. Today was the first day of the Turkish Psychiatry Conference. It's here in Ankara. And the main theme is evidence-based therapies and how to make them more evidence-based. So most of the topics and conferences are on the same topic. And one quick question: when you were talking about comorbidities, I had the impression that you would touch upon network theory. Was I wrong? I mean, would you like to say a few words about network theory, because it may have, I mean, it's a very new thing. It's an improvement. It's an innovation. It may work well in comorbid conditions. What do you think?
Yeah. Wow. That's a big topic. There's been really, to sort of put this in a nutshell, sort of two dominant approaches, as you know, obviously, to characterizing, conceptualizing psychopathology. One has been the one embodied in the DSM, where you get these discrete conditions that are, their presence is reflected by the symptoms, right? So you have someone who has anhedonia and early morning awakening and sadness and suicidal thinking, hopelessness, These are all reflective of the disease entity, so to speak, of major depressive disorder, right? And so the symptoms are seen as sort of independent consequences of a common cause. And so, for example, someone who has, it's the same sort of model in some sense. If someone who comes into the doctor and he's got a fever of 103, a very sore throat, difficulty swallowing, fatigue, and little white patches at the back of his throat, and they go, oh, it looks like these are, in fact, the signs and symptoms of strep throat, right? You know, a bacterial infection versus a viral condition. And so then you give the person penicillin and boom, all the symptoms go away, right? And so there's been this sort of implicit model that's kind of like that, or an oncological model. Someone has a tumor and then they get signs and symptoms of say, lung tumor, for example. Okay, that's one kind of approach to look at it. The other is the dimensional approach, right? There are these latent dimensions that you can sort of characterize people, neuroticism and extroversion and so forth. The network approach is very, very different. And Denny Boersboom, who's not a clinical psychologist, he's a psychometrician. He's sort of a measurement guy. Denny is the person who has really pioneered this. He's at the University of Amsterdam, and now it's all over the place right now. And but what he was saying here is that he says maybe a better way of sort of conceptualizing mental disorders is really when someone would say a major depression, the depression is not some disease entity that is the common cause of its symptomatic expressions, but rather you've got different elements, sleep and rumination and anhedonia, et cetera, that are interacting. And so you get these sort of elements that are interacting, and the state of depression is sort of an emergent property of a network of interacting components, which is a very, very different way of treating things, which is quite different. And so it's not as if you're going to give sort of the psychological or psychiatric counterpart of penicillin. You're rather going to target the different symptoms and the connections between them. And this is the network theory really comes out of physics, really early physics in the early 20th century. But there was that's the theory, but not dealing obviously with the stuff we're concerned with, signs and symptoms of mental disorder. But the computational power was not there to do this, and so computer science and statistics, mathematics have really caught up, where you can actually study the dynamics among symptoms, either cross-sectionally or longitudinally. So it's an entirely different way of going about this. And so in comorbidity, the idea here, like you have, say, generalized anxiety disorder and major depressive disorder, which often go together. And yes, they have some shared genetic correlations and the like. But then you've got symptoms, say, like a sleep disturbance, insomnia, or rumination, or things of that sort, that sort of are symptoms that are kind of shared by both of these. And the idea that you can get comorbid conditions if some of these symptoms get activated, and then they sort of generate activation to the two syndromic clusters. And so rather than the hallmark symptoms that are sort of associated with only one syndromic cluster being relevant, the ones that are the non-specific symptoms, like concentration impairment, insomnia, which happens in a lot of conditions, those may even be more important, because if you can deactivate those, you're going to help deactivate the other symptoms in the two clusters of which they connect. So this is a whole, I didn't even want to go near network census approach, because it's just a very complicated area.
I know it's a very, very wide area. So that's a good nutshell for me. Thank you.
Yeah, it's probably a longer nutshell than we need.
Yes. Thank you. Thank you.
But yeah, it's a totally different approach to comorbidity. That's the short answer. Yeah. Okay.
So,
Özlem.
It seems that there isn't any more questions, so we can go back to Dr. Başoğlu for his presentation now.
Okay, so I've got the rest of the evening, I guess, until
the morning. Yes.
Exactly.
If there are any, there will be any people left in the
only the most motivated.
Right.
But can I just try the share screen first, just to make sure that it's working?
Yeah, of course. Yes, of course. I mean, you're also a co-host. You can try.
Okay. Do you see anything?
Metin, first of all, let's go unshare the screen. Stop share. Stop screen share.
Okay.
Now, first of all, do you have the document open on your computer?
Yes.
Okay. Then you just hit share screen, as you did a while ago, a minute ago.
Just a minute. Okay.
Hit share screen.
I did.
You did not. You did it a while ago. You did it a minute. Okay, great. Now can you see the? Bir dakika Metin. Okay, great. Okay, fine.
Can you see it?
Yes.
Okay, great. Okay. With the time left, I'm going to go through the work that we've done on developing an alternative treatment, a treatment alternative to cognitive behavioral treatments. And I actually did this talk one of the previous times. So I don't know how many members of the audience had been in that talk, but I'm not going to present the whole stuff. I'm going to present a brief summary, as brief as possible, which I hope will enable me to raise some critical outlook on psychotherapy in general. Now, as you know, I'm assigned the role of the devil's advocate. So nothing personal, by the way, Richard. I'm going to be talking about sort of general psychotherapy, mainstream thinking around the world. But first, let me just, let's go visit the memory lane. I'm going to show you a picture. I don't know if you recognize that picture or you remember it. Do you? This is the year we met in Philadelphia.
Philadelphia, 1985. Yeah.
Was it 85 or 86?
85. It's fall 85, of 85.
Okay.
Yeah. It's
okay.
Monica there, and oh yeah.
Yes, there you are with a mustache.
Yeah, mustache.
And that's Susan. That's Edna Foa.
Yep. Right.
That's Isaac Marks, and that's Gail.
Yep.
Michael Kozak, right?
Kozak, yeah.
And myself here, also with a mustache.
Also with a
mustache. Richard and I have been very long-term friends. Met in 1985. Since then, we've been regularly in touch. We actually got involved in joint projects from time to time. We kept in touch over the years. And when I edited my first book, 1992 book on torture, he was a contributor to that book. And then after the earthquake, he came and visited us. We went to the project site in Gölcük together to make some observations and so on. So he closely followed our work. And lastly, he was also with us in 2013 as also a contributor to my last book that came out on 2017. Anyway, so when the two of us come together, there's really no stopping us debating issues. We can go on for hours and hours and hours without getting tired. And this is actually precisely why he is here with us, because Jem jumped at the idea of inviting me as a speaker when he heard that the two of us coming together is an explosive combination. So he wanted some excitement. So Jem, you'll be getting that excitement tonight.
Okay, great.
Now, Richard, you mentioned in your presentation the concept of control a few times. You use the term agency also. Now, this is typical of the general literature in anxiety disorders as well as in trauma. It's not a foreign word. It's not an unknown concept. It has been used and its importance has been appreciated to some extent. But somehow it has never been the center of attention in psychotherapy research. In my view, it's a central concept. Just like anxiety, as you said, is an evolutionarily determined emotion necessary for survival, so is control. The need for control over environment is also a necessary condition for survival. So it also has genetic origins and evolutionary origins. It actually reflects on everything we do in life. Everything we do is designed to achieve and maintain a certain degree of sense of control over our lives. And to the extent that we can maintain that control, we are in good mental health. And to the extent that we stray from the control issue, then we begin developing psychological problems. Now, of course, you know Seligman's work. He demonstrated the importance of control, or in other words, the importance of unpredictable and uncontrollable stresses in traumatic stress in animals, as you know. So in early 90s, Susan Meinicke and I got together. You may remember this chapter. It appeared in our 1992 book. It was the first time attempt to bring together animal literature on what we know about the importance of control with human, combine the two or examine the parallels between animal response to uncontrollable shocks and human responses to torture. So we combined our knowledge of the respective issues and wrote this chapter. This was the beginning of our journey over the years. Basically, what we said in that chapter is both animals and humans show a greater response, more severe stress responses to unpredictable and uncontrollable stresses, okay? If that is the case, then we said, we generated a second hypothesis there. If lack of control or loss of control is the primary mediator of traumatic stress, or any kind of stress for that matter, or anxiety, then the most effective possible way of treating that condition is reversing this process. In other words, helping the person to gain control over the stressor itself or over its consequences, over life in general or over particular stresses. That was the second hypothesis that was generated by this learning theory model of trauma. And this diagram depicts it very briefly. Basically, it must be very familiar to you. If someone has had a previous experience of control over stressors, then the person can effectively deal with the situation, the stressor situation, gain control over it, fight or flight response, and then sense of control is reinforced, sense of control over future stresses is reinforced and strengthened, and this is a positive outcome. In other words, resilience. If that doesn't happen, if the person doesn't have prior experience with similar stresses, it's a failed fight and flight response. Loss of control over the stressor event occurs. This leads to uncertainty about future, which is helplessness, anxiety, which in turn leads to PTSD, other anxiety disorders or other psychiatric disorders and physical illnesses. Now, if this evolves into certainty about future helplessness and hopelessness, then this becomes depression. And of course, in a mass trauma situation, I adapted this model to mass trauma situations because a lot of stresses occur after major disasters, like loss of close ones, loss of resources, and other life stresses. These also contribute to certainty about future helplessness and hopelessness, which also goes back to depression. So these are causal pathways, if you like. And this is not my theory. This is, learning theory, basically, as you know. There's one thing new in this diagram that is my own contribution, and it is this, what I call the pathway of natural recovery processes. What happens, and this is based on my observations after the earthquake in Turkey in 1999, we very frequently observed people who by themselves engage in self-exposure and exercise self-exposure in pretty much the way that we would have prescribed it. In other words, they were not able to go into their homes, even if their houses were not damaged and safe and so on. They stayed in tents. You've seen the locations, you remember, in shelters and so on. And many of them at some points decided to go back to their homes in great fear, actually. And I have actually videotaped some sessions of this happening without our participation, without our intervention at all. And I've seen them practice self-exposure in much the same I would have prescribed it to them. Many people discovered exposure by chance, by accident, or sometimes by obligation, because when they had to move back to their new houses, that's an exposure situation for them, right? So they're exposed to a situation where they think they might re-experience earthquakes again. So this happens at this point at the anxiety level, or it could also happen when anxiety is combined with hopelessness and therefore depression. There's some people somehow manage to discover self-exposure as a way out of severe anxiety and depression. And this leads to, again, this positive outcome and resilience. Now, this is a model that I've spent I'm sometimes reluctant to say this, but 30 years to prove. All these pathways represent causal relationships. This, in fact, reminds me sort of your network analysis. There are some differences, obviously. Yours is based on symptoms only, right? Mine includes some mechanisms, processes that are possible mediators of improvement or traumatic stress. But basically the methodology used here is the same to provide evidence to show that these are actually causal pathways. One thing leads to another. Anyway, we spent 30 years on every bit of this diagram to come up with empirical evidence about the causalities between these processes. And I won't go into that kind of evidence because obviously there is no time. But this implies that, okay, if an enhancement of sense of control reverses the traumatic process, then all you have to do in treatment is to get them in a situation that they can have an opportunity to overcome distress and anxiety, okay? This may be anxiety tolerance, you can call it anxiety tolerance, or sense of control over anxiety. Those two concepts are different though, they are not identical. They are not the same outcomes. There are differences between them. If there is time, I can go more into that issue. Anyway, this actually eventually led to a very simple intervention. Okay, nothing really complex about it. It's focused on one symptom of PTSD, and that's avoidance. It could be behavioral or it could be cognitive. Okay, and of course, avoidance is fear. Fear first, then avoidance, then helplessness. Those three concepts are very critical in this model, okay? These are the causal processes that explain traumatic stress. So you identify avoidance behaviors and give the treatment rationale. The treatment rationale here is different from classical exposure treatment. It's not aimed at anxiety reduction. We don't aim for anxiety reduction. We aim for sense of control over anxiety or anxiety tolerance. It's kind of, we use an analogy, in fact, to explain this to patients. It's like a vaccination. In principle, it's the same process. Vaccination is a weakened form of virus injected into the body, and the body develops immunity, okay? Exactly the same principle. Anxiety here, exposure to an anxiety-evoking situation is like a vaccine, is like a virus itself. You give it to the organism, and the person has an opportunity to gain tolerance or sense of control over it, okay? This we explain to the patients using this specific analogy. They understand it very well, especially in this day and age of the pandemic. And many of them can relate to the rationale very nicely, very high rates of compliance, over 90%. Actually, and then we give self-exposure instruction. In simple words, we say, don't avoid when you come across any situation that causes distress, anxiety, or fear, don't run away. Stay there until you feel okay, until you feel it doesn't, anxiety doesn't have to reduce. You can finish the session with as high an anxiety as you started off with. Doesn't matter. The important thing is that you stay there and you conquer your fear. We present fear as kind of an enemy to fight back, fight against, because it has consequences. Fear and avoidance is a major cause of social disability in trauma cases, as well as in other anxiety cases as well. So they relate to these instructions very well, and then that's it. Basically, the rest of it is you just monitor progress if you deliver the session in more than one session. Now, in the earthquake times, okay, this is what distinguishes, these differences are what distinguish CFPT from CBT or from exposure treatment, for that matter. This is not exactly exposure treatment either, because it's not based on a habituation paradigm. It's based on a control paradigm, okay? Right, so let's move on. Okay, this slide, we did several studies. Okay, these, study one is earthquake survivors. You may remember these studies. You were there when we were conducting them. We gave them one session because at the time we didn't have, you know, we had to deal with thousands and thousands of people. We couldn't see them for more than one session. There was a lot of demographic mobility in and out of the earthquake region. So we said, well, we got only one shot, you know, whatever we get in the end is what we get. So we gave the treatment in one session. This is the first study. These are randomized control studies, by the way, these two studies. And there's a gradual improvement. It's spread over 6 months in both cases. The second study is this one. We used an earthquake simulator as part of the treatment. We gave them a 45-minute session because we had discovered that the sensation of trembling, the tremors, was the most traumatic stressor among all the stressor events that earthquake survivors experienced at the time, for some reason that I won't go into. So we thought, well, this is the UCS, the unconditioned stimulus, right? It's not conditioned stimuli we're exposing them to, like reminders of the trauma, but we're exposing them to the trauma itself in a simulated fashion. Okay, since we cannot create earthquakes, we can simulate them at least. So there's a difference between the two. They improved even more than the other group. And this third group is the most recent study that we did. You may not know about this study because it's not published yet. This is asylum seekers, war and torture survivors in Turkey, in Istanbul, 60 cases like that. And they were mostly from African countries, some Middle Eastern, Iran and Afghanistan and so on. These are the most severely traumatized cases I have ever seen in my career. A CAPS score of 85, extremely severe. Women who've been abducted, raped, gang raped, family killed, sisters, brothers, family, and then running away from the country into exile, coming to Turkey in dire circumstances, in poverty, and so on. Amazing stories, really. I mean, remarkably severe cases. In this study, we did not give a single session. We gave the whole full course treatment. The main purpose was to understand, to find out how many sessions it took for significant clinical improvement to occur. Okay, recovery was faster than in the other studies, obviously, for obvious reasons, because it was a more intensive treatment. But in the long term, in 6 months, they converged. So when you give a single session, improvement is slow. When you give the full session, improvement is faster. But at the end of the day, they all converge. So you get the same results, whether you give one session or the full treatment. Now, these studies, I often raise the question. I told you about what the treatment involves. It's a very focused treatment solely on avoidance behaviors, and no cognitive interventions, no systematic cognitive instruction or anything else, no other anxiety reduction strategies like breathing training and so on, relaxation, whatever. You just focus on behavioral avoidance, sometimes cognitive as well. In the asylum seeker case, we used also the unconditioned stimulus to the extent possible to recreate the traumatic events by actually showing them videos of violence, war movies, rape movies. We had a whole sort of arsenal of videos, gory stuff. And we had them watching these videos for like 2 hours, 3 hours every day for a while. A remarkable response, and looking at the level of improvements here. This is the earthquake. These are the earthquake studies. These involve 4 studies that we did. I didn't mention the other 2 because they were not control studies. And this is the asylum seeker group. And this is percentage of overall improvement. I actually searched the literature to find meta-analytical studies of different treatments to make a comparison between CFDT and other treatments. This is taken from Bradley et al. 2005. You may know the paper. It's an old study, but I couldn't find really more recent studies that show within group effect sizes. In fact, effect sizes are shown here. Let me go back to the other slide. Many of them, as you know, report between group effect sizes. But I had to make the comparison based on within group effect sizes because in one study, there was no control study. In the other control studies, earthquake studies, the control comparison was made at week 8, whereas the maximum improvement levels were achieved at 6 months. And so we couldn't make a control comparison at 6 months for ethical reasons. We couldn't keep the control group without treatment for that long. So and when I saw the improvement trends continuing over 6 months, I decided to use between group effect sizes to make this comparison. And there were very few meta-analytical studies that reported within group effect sizes. That's why I had to make this comparison based on within group effect sizes. But it gives you some idea about the strength of treatments here. This is the asylum seeker group, completers. Completers analysis is of interest to me because it refers to efficacy of a treatment, as you know, not effectiveness, but efficacy. In other words, if you have a group of patients that receive your treatments without any failure, they all go through the entire treatment protocol, is the treatment effective? That's the question that this effect size addresses. It's a huge effect size, as you can see. But if you include 20, there were 20 dropouts in that study. If you include the dropouts, in other words, if you make it an intent to treat analysis, it comes down to 2.03. And this is the treatment of earthquake survivors, 2.48 effect sizes. These 4 studies combined. Now, if you make a comparison, this is exposure treatment, classical traditional exposure treatment that you've been talking about. This is cognitive behavior therapy. This is exposure plus cognitive interventions. This is EMDR. This is mindfulness, by the way, mindfulness-based treatments. This is taken from another meta-analytical study, Boyd et al., 2018. Actually, there's a mistake here, 2018, not 2001 or 8. Anyway, I'm really very modest effect size here, 0.94, and this is supported psychotherapy, and this is weightless control. Here you can see the difference between, these are single session, this is a single session treatments, an effect size of 2.48 compared with effect sizes of this magnitude. Now, I put this question to every audience I addressed. Last time it was in Oslo, I gave a keynote address to the ESDSS conference, and there were like 600 people in the audience. I said, look, this is what we did. This is the treatment. These are the results. No cognitive intervention, nothing of the kind, nothing else, just a very focused treatment. In some cases, 1 session here. In some cases, 6 sessions. This is an average of 6 sessions, by the way, the asylum seeker group. Somebody has to explain this finding to me. And of course, there was everyone in the audience. All the representatives of different psychotherapies, EMDR, cognitive, CBT, you name it. And no response, total silence. Every time I do this, I need an explanation for this finding. Somebody has got to explain this to me. How is this possible? That would be my first question to you, if you can make a note of it.
Metin, ask him to reply, to answer you now.
Okay.
Okay. Oh, so, is that to me? Oh, yeah. Okay.
Yeah, right.
Yeah, I think it's terrific findings. You mentioned, I think that probably the distinction you drew from you said exposure treatment, and then the mastery treatment, or however you want to designate it, the one that you use with the torture survivors and the earthquake survivors, they're very, very similar to just standard exposure therapy. What the interesting difference is that the rationale may be the difference maker here. So, for example, the notion that the original one, think of the Foa and Kozak classic paper, right? So exposure therapy, right, is exposure to corrective information. Well, that's certainly true. But the idea was that you have the within session habituation. So the goal is your anxiety to go down within a situation. And as you continue to practice, as I drew in the Luana-Markey's graph, then the next time you do it, you probably won't be quite as anxious, but it will also go down the within session. We now know, Michelle Krask and others have shown that the within session habituation, as you actually mentioned this yourself, Metin, is not essential for the improvement. And I think the difference here is that the exposure therapy is only dealing with a procedure. But there is a theoretical habituation rationale that motivated its development. There's no question about that. And I think the real difference here is that if the rationale is confronting situations that are no longer objectively dangerous, but are provoking fear and anxiety, and really the idea here is to make you master the emotions, make you the tolerance of them. It's not to reduce their fear, but simply to be able to do things in spite of it because you become more tolerant of it. And parenthetically, the fear may decline and the symptoms may decline as a result of that. But that's not actually the avowed rationale. Whereas the exposure therapy is to reduce the anxiety in the situation. And that's the goal, as opposed to enabling you to tolerate the anxiety in the situation. And it seems to me that that might be the first clue to an explanation for why you get these very impressive results without a complicated program, and also doing it quite efficiently. So I think there's something here about the agency, the mastery, and the tolerance of the emotion, rather than seeking to reduce the anxiety as much as we can, as quick as we can. I think that rationale might provide the clue to the explanation. That's my first take.
Yeah. I mean, look also at this slide. Look at these are percentage improvements.
Yeah.
You see, this is also in response to Mehmet's earlier point about the two approaches yielding the same results. They don't seem to be yielding the same results. Look, this slide shows you that very clearly. This is exposure treatment. The average improvement rates achieved by so-called evidence-based treatments are about 50%.
Yeah.
They take these for 53, 56, 47, 60, you know, in the range of perhaps 55%, 50, 55%, which means half of symptomatology remains. It's partial improvements. In contrast, look at the improvement rates we get CFBT. This is the asylum seeker group, 93%. Self-rated, by the way, not assessor rated, but this is rated by the patients themselves based on the global improvement scale. You may be familiar with this scale.
Oh, yeah.
Commonly used in psychotherapy research.
Yep.
So it's not our opinion. This doesn't reflect our opinion as an assessor. It reflects the patient's own estimation of their overall improvement status. 93%. And this is the earthquake study, 88%. Now, this means, I mean, like CAPS scores below 20, they represent like almost complete recovery or with mild symptomatology. So there's a big difference in the outcome that you can achieve between different approaches. Of course, the ideal way to examine this would have been to have a controlled, randomized control study comparing CFBT versus traditional exposure treatments or whatever else you may want to compare it with. That would have been ideal, but we never had a chance to do that. But an alternative way of doing it is the meta-analytical comparison. Look at, you know, percent improvement rates or effect sizes and so on. It also gives you an idea. So what we get with evidence-based treatments is really, really modest improvements. Really nothing really that much to write home about.
Well, if I could jump in for just a second though, but compared to psychotherapy, supportive psychotherapy, it's quite substantial. And also in supportive psychotherapy is also twice as good as waitlist. And so it's sort of interesting because it's all of these actually are better than the waitlist control. Everybody's better than that. Look at it. Yeah. So there's clearly so even supportive psychotherapy is not that bad. Then you got to go EMDR there, 60. Wow, how about that?
Yeah.
So clearly, but I think you mentioned two different things here. This graph shows the improvement, right? The percent of improvement. But I think the other thing that you also added, you also mentioned the final CAPS score. So in other words, the actual not the percent of improvement, but actually where were these people at the end of it, right?
Exactly.
That's also important because sometimes you can have people who have shown great improvement, but be still very impaired, largely because they were in such bad shape to begin with. You think about the torture survivors. Oh my gosh. I mean, that is, oh boy. I know we've talked a lot about these experiences in some detail. And I remember at one symposium, some of your diagrams and just simple drawings were so startling that people couldn't follow the rest of what you're talking about. It was really shocking stuff. And so you think of any group that's going to have show improvement, if anything, it might be those guys, but also you would expect them not to be at the highest end state functioning either, but they're that as well. So they're showing a lot of improvement, but also their end state rating is quite good. Relative to most of them. So that's very important. It's just not a matter of percent improvement, but it's about where are they at the end.
Yes, I mean, these are overall global improvement rates, but not shown in the graph. In the slide is percent reduction in PTSD symptomatology. In other words, percent reduction in CAPS scores, total CAPS scores, 85%.
Right. Yeah, that's really high, and also the final cap scores also shows quite well. Yeah. So both of those. Yeah. Yeah. That's very, very impressive. Now you those slides are great. I'd love to show those to my class if that's possible. I don't know if you, or maybe you have to get it published first. But have you submitted that, or? I know it's an open trial, so I know that's a problem, but the results are so powerful.
Well, it's an open trial, but we had a chance to do multiple baseline experimental design with 25, with a subset of cases, 25 cases. They had 2 assessments within like 2-3 weeks apart, and there was no improvements during that time.
I see.
Based on 25 cases. So, I mean, it does mean something. I mean, at least 25 cases, we know that improvement is not attributable to non-specific factors. In any case, you don't get this kind of improvement with non-specific factors, can you? I mean, like 93%. No. Yeah, especially with events, we have evidence from our own randomized control studies that CFPT is a highly effective intervention. So there are several lines of evidence that actually kind of cover up for that weakness, if you like.
Right, they sort of compensate.
It's going to come out later this year, at the end of this year, I think.
Where?
In the journal Torture.
The journal Torture?
Yeah.
Oh, okay.
It's actually
that's an interdisciplinary journal, right?
Yeah. It's a summary of the results. Actually, I'm not reporting the entire data, but I'm reporting some of these slides as well in that. I'll send you a copy when it's out.
Yeah. Please do.
I can give you the slides as well.
Yeah, that would be good. It's really interesting.
Metin, you did not, bir dakika, Mehmet'in bir sorusu var ama just one moment, Mehmet. Metin, you did not share this with us before. I mean, like Richard did with his presentation. Would you mind sharing this with the group?
Yeah, I can. I did these slides last night, Jem, that's why.
No problem. I mean, you can share them yourself or send them to me, but they might be too large. They should not exceed 8 megabytes. So
I can
maybe
divide
you can
them.
do. Okay. Mehmet. Pardon, Özlem sen buradasın. Senin görevini üstlendim. Ama Mehmet sesini aç istersen. Özlem devreye gir.
Tamam.
Mehmet sorunu alıyoruz.
Has a question. Yeah.
Thanks for the presentation. My question would be more about, one of the problems with trauma-focused treatments is matching the type of intervention with the type of the trauma. So that is a very important issue in trauma-focused therapies. Some kind of treatments are good for some kind of traumas, while others are not that good but that doesn't give a general idea about that this treatment could be efficient in every type of treatment. That's one thing, because this is one of the main, we are not adjusting the treatment according to the needs. The type of trauma actually requires every different type of trauma might require a different trauma-focused treatment. And if I didn't mishear you, I had missed some of it, but you were talking about...
Let me just say, we used exactly the same protocol with war survivors and earthquake survivors.
Okay, great, thanks. The second question is, I heard that you were talking about the global impression, which is self-report. Of course, global improvement and specific improvement are two different things. Did you say that the CAP score is also relevant or kind of related or proportional with the global impression stuff?
It is. They are very highly correlated.
Yeah. Okay, thanks.
Yeah.
In fact, as I said, 85% reduction in PTSD symptoms. This is the specific outcome measure that you are asking for, whereas this is 93% is the patient's own ratings of improvement.
Mm-hmm.
And they correlate very high, obviously, because they are both very high.
If they are correlated, there's no problem, because otherwise, some people sometimes, take kind of advantage of the relationship issues, the time spent with them, the care and so on, not necessarily specific, because global impression shows the global impression, not the specific improvement. But when you say they're correlated, then that's something great. Thank you.
Not global impression, Mehmet, global improvement rating.
Global
improvement. Is global improvement rating.
Yeah, but then what is the question to ask that global improvement? How much do you feel you have improved since the beginning of the treatment?
Since the beginning, It's
so it is like a global impression. It's similar, but it's, instead of saying impression, you say improvement.
Yeah, there's an assessor rated version of it as well. Clinician,
and do they correlate as well?
They correlate as well, yeah.
Great, thank you.
I usually choose the self-rated ones because
it most reflects more
bias, you see.
Yeah, sure.
Mm-hmm. Okay. Metin, anything more to say? Are you finished or?
Well, a few more comments, if I may, if we have time.
Please. No, it's up to you.
Yeah. The cost effectiveness issue is important. Richard also commented on it.
Yeah.
After the earthquake, we made some calculations to figure out how much it would cost to deliver treatment to millions of people. It's a topical issue in Istanbul at the moment because we are expecting a big earthquake, as you know. And there is a model that I haven't had time to go into, but in that paper that you attached to the email, Jem, there's a full review of that model, the treatment dissemination model. There is a certain way of disseminating treatments to masses of people who've suffered from mass trauma. We made calculations. There's also, as I mentioned, a self-help delivery manual, which we can distribute to the masses. And without the help of a therapist, they can administer the treatment themselves. We've tested it out in a pilot study. We get the same results as we get with therapist-delivered treatments. And we use it with thousands of cases after the earthquake with pretty good results. So this calculation doesn't include the use of a manual. It's a little bit outdated for that reason. It doesn't include the manual. Otherwise, the cost of delivery would have been much less than $3 per case. If we wanted to deliver treatments, care to, let's say, 1,000 cases, it would cost us $3 per case. And if we use the self-help manual, about 1 in 4 cases read and utilize the manual according to our preliminary research, which would then make the costs per case much lower than $3. So this means that we can actually, when there is an earthquake in Istanbul, Istanbul is a population of 15 million. Probably in our previous research shows that the percentage of people who will be in need of treatment will be 50% based on our previous findings. If you go to them and then do you have problems that you think may require treatments, 50% of them say yes. So we are expecting half of the survivor population to be in need of treatments. That would mean like 8 million people, 10 million people. And so I'm now working with the Istanbul municipality to, in the way of preparing for the earthquake. I mentioned this model to them. If they are interested, then they may want to implement it in the future when the time comes. So there is a cost effectiveness issue, which is also very important because we are talking about mass trauma here. Treating an individual patient is an issue. Okay, it's an important issue, but then when you're faced with a huge mission like delivering treatment to millions of people around the world, not just natural disasters, but wars and you name it, everything, then you really need something. You need an intervention that is distributable, that is cost effectively disseminable to millions of people. And there is no other evidence-based treatment suitable for this purpose. And if there is, correct me if I'm wrong, Richard, and I will stand corrected. Okay, I've got some other issues that might have been of interest to you. About the issue, you know, this control thing, I keep wondering to myself, after 30 years of work on the concept of control, you know, initiated by Seligman, why don't people appreciate the importance of this concept? Why don't they ask the question, you know, if control is the central issue here, psychotherapy should take this concept to its core. And the question should be, what is it that we can do to help a person regain control over stress processes or stressful life events or traumatic stresses? How can we help the person to gain control, regain control? There are different ways of doing it. Exposure is one of them when it comes to trauma or some anxiety disorders. A very important method of helping a person regain control, but not the only one. There are many other things that you can do to help a person regain control over life in general. So that should have been the central question in psychotherapy research around the world. Now, interestingly, the mental health care professionals sidestep this question. Not that they are totally ignorant of it. They know, they realize, they appreciate its importance, but they never made it a central issue in their work, except for some people and some institutions. You know, we know who they are. To name one of them, CIA.
Oh, the CIA.
I mean, it's
oh,
you know, it's a bitter irony.
Oh, yeah.
I mean, there's a long story behind it. I don't know how much time you want listening to me here, but they have invited Seligman himself to give a talk to the CIA at the time of the Bush administration,
right,
to develop enhanced interrogation techniques to extract information from the so-called, you know, perpetrators of the Twin Tower incident, the 9/11. People who actually allegedly committed those acts. And he gave a talk to them. Now, and they recruited 2 psychologists. You know these guys, I'm sure, Richard.
I know of them. Yeah, I don't know them personally. I think one is dead and the other is still around. Yeah.
Is he? I didn't know that. Which one?
Oh, geez, I forget.
Not James Mitchell, I don't think, or maybe the other one. I know that James Mitchell is alive.
Yeah, that must be the other one.
Anyway,
yeah.
These 2 guys, there was a huge controversy over this issue in the States, as you know.
Oh, yeah.
They commissioned these guys, paid them $80 million to help interrogators develop enhanced interrogation techniques. And what sources did they use?
Yeah.
This
boy.
Chapter. They used my chapter to do it.
I didn't know that.
Yeah.
Interesting.
I mean, this is the first time I'm mentioning this in any talk.
Yeah.
Published in this book.
Yeah.
And then I've got other evidence. Some American media outlets actually contacted me and sent me these documents. These are actually declassified secret documents obtained from the case against those two psychologists, supported by the ACLU, the American Civil Liberties Union. Apparently, these guys, the two psychologists, advising each other to have a look at our chapter, because it would give them a good idea how to extract information from them. Basically, the issue there is how to remove control from the detainees, how to put them in a situation to make them totally helpless so that they can extract the information they wanted from them. I mean, when I heard about
Metin, yavaş yavaş toparlayalım mı konuyu?
Yeah, okay.
Dağıldı biraz galiba.
Okay, all right. Anyway, so the point here is some people know what the central issue is, and they are using that information. And unfortunately, these are the designers of torture doing that. But when it comes to mental health professional community, I don't know, somehow they overlook, what explains this? This is what I've been wondering about. Maybe you can comment on this.
Yeah, sure, absolutely. Yeah, well, I think the issue about control...
Richard, may I interrupt again?
Sure.
Just one moment. Metin, you know, we're recording this. Do you want this all included? Not that I'm worried, but would you mind these being recorded?
We can discuss it. You mean, so we've already discussed it.
No, it's not too late. We can have it chopped off at the end or whichever. It's up to you. You don't have to say yes or no now. You can say it.
We can discuss it later.
Okay, fine. Okay, go on.
Yeah, I'm going to have to run myself here to go see how these do. But I do want to respond to Metin. The issue about control, mastery, etc. These things they pop up in a couple of different ways. One is that there's been a whole lot of work on this is not cognitive therapy. This is information processing, cognitive biases, attention, And there's the issue about executive control and attentional control. This is control in the cognitive sense. There's a lot of paradigms for doing this, and so a lot of the some of the information processing abnormalities, if you will, seem to be partly predicated on difficulties with executive control. That's coming out of the clinical research. But the other one that's a little bit closer to what you're talking about, I think, is with some of the, I mentioned the unified protocol in this issue about mastery and agency and going and tolerating emotions. And emotions more generally, we're talking about anxiety and fear typically. But in terms of other sort of emotional avoidance and trying to master those. So you do see some of this control issue popping up in different places, but it's not the sole emphasis, I don't think, not as much as an emphasis here, certainly with your program, but in ones that are, a little bit longer. But you do see that, I think, coming up that is not necessarily in the traditional habituation model, but in terms of tolerating emotions and not avoiding emotions. This is like the Barlow thing I've been referring to. And they did a paper a number of years ago. Barlow's group, it was in Psych Review on panic disorder. And they were talking about previous exposure. Sue Meinicke was involved in this, and that's probably why, partly. But the issue about prior experience with mastery and control is one of the variables that can either a buffer or the lack thereof increase risk of people developing things like agoraphobia and panic. So you see that as part. You see the control appearing in some of these theories as one component among others, like anxiety, sensitivity, or what have you. And so you do see it in a couple of these theories, and then you see it sort of in an applied sense about tolerating emotions, where the emphasis is not just anxiety or fear reduction, it's instead of the Foucault-Kozak, sort of an approach. So it's still exposure therapy, but the rationale is somewhat different. So there are some people that are sort of stumbling on that. That's a little bit different than the attentional control issue, because that's not directly dealing with emotion. It's about dealing with, and that spans a lot of areas, right, too. So attention deficit disorder and things of this sort, and being able to regulate attention. And also, so you do see some of these things, but probably not. It's not foregrounded nearly as much as you have here, where that is really the main focus, and especially dealing with highly disseminable programs where you can reach a lot of people at a very low expense. Where if you're going to do anything, do the control. I think that's the message that comes out of your slides here.
One more point I'd like to make quickly, Richard, that might be of interest to you, to your network theory, basically. Because I read your paper very late last night. You sent them very late in the evening.
I sent them very late. He sent them a lot earlier, but he sent it to both of us.
Oh, let's see, because Mehmet, there's some, Mehmet and I were talking in New York at ABCT a few years ago, and I was going to send him a couple of papers on PTSD, network papers, and I couldn't get it to him. And then I got the email from Mehmet, and now I got the new email, and it worked. And I sent him another one, which is a recent article that sort of pulls together a lot of the methods. And maybe that's the one you're referring to. And I sent those to Mehmet, and so maybe he sent them to you and passed them around. I don't know, but
the one.
Oh no, you were CC'd on that. That's right, Mehmet. Both of you guys were. Right. That's why.
The one entitled "Mental Disorders as Causal Systems."
Oh yeah, that was the original study. Yeah.
Right. Okay, that's the one I read. And actually, something struck my attention there. In the discussion, you say that this kind of analysis is useful because it can lead you to discover sort of certain symptoms that might have relevance to treatment interventions.
Or things, right? Potentially, right? That's right. Those high in certain centrality metrics and things of that sort. Right. And targeting those would propagate.
Which means you can actually focus on certain symptoms, and then you can find improvement in other related symptoms. Okay, that was the idea as far as I understood. Now here's a finding from one of our studies.
Metin, I think Metin and Richard. Just one moment, please. I think we've gone beyond the scope of the meeting now. Let us, all those people who wish to leave are, of course, more than welcome. But we can continue. They're also welcome to stay behind and listen. But we're going beyond the scope. So, ayrılmak isteyenler doğal olarak ayrılabilir. Oturumun kapsamının dışına çıkıyoruz ama biz biraz daha devam edeceğiz. Metin and Richard will be talking and will be listening.
I also have to. I mentioned the other Zoom that we have a speaker in my department from New York.
Richard, you've been saying that for the past 3 hours. But
no. I've been joking about this. Is my third one coming up. I'm not speaking at this one.
Right. And I'm just kidding.
Yeah, so I'll need to transfer over there because she just started. So. I'll be joining that speaker.
Okay.
But so maybe we can tie it up quickly. That would be great. But so just to answer, Metin, that's right. So at least theoretically, symptoms that have, we say, high outstrength centrality, in other words, that are kind of the source of keeping other symptoms alive. If you can turn down the volume of that one, you should have beneficial therapeutic effects much quicker than if you target some other ones that are so that's some of the clinical implications. And now some of this is being tested right now, so it may not be true. but at least theoretically that would be the case.
But data show that when you focus on avoidance,
Right.
every PTSD symptom improves.
Yeah.
Every
Yeah.
one of them. And this
Yeah.
is what the slides show.
Yep. Yeah.
I thought that might be of interest to you.
Very much so. Right. Yeah. I'd love, yeah. Yeah. If you could send me those slides, and if you got the citable paper that goes with it, or whatever it would be, a talk or something, that would be, that's exactly right.
Yeah. We keep in
Yeah.
touch about them. Yeah.
Excellent.
Okay. So that's it then.
Okay,
Okay,
great.
great.
Yes. Okay. I noticed the
Richard.
audience has dwindled a little bit.
Okay, now the acknowledgements. I wish to thank first to Metin, because he brought you over to the meeting, Richard, and he helped me a lot to put the show on the road. Maybe it's the other way around, but still. And I wish to thank you, of course, for joining and staying with us, although you should have left about 3 hours ago.
No.
Well, no, it was a pleasure to listen to you, seriously.
Likewise.
And
Thank you.
seriously. And I hope you'll be in touch, and maybe we can sort of send you an invitation for another English-speaking meeting in the future, which we have done in the past. And I wish to thank, of course, to Özlem, who is probably half asleep now. What give Özlem? Okay, Özlem, thank you
I'm
very
still awake.
Okay. And then thank you for staying so late and moderating the show. And Cengiz, you too, for your contribution. And there are 10 people left. And who else is there? Idil and Mustafa. Probably they're sleeping. Their videos are turned off. Probably Mustafa and Idil are sleeping. But never mind. Okay. Dilek sana da. Dilek, thanks very much to you.
Bye-bye.
And then we'll see you all.
Çok teşekkürler düzenleme için, davetiniz için.
Rica ederim. O İdil uyumuyormuş. İdil videoda işte
It's I can't turn on my camera, sorry, but thank you for all the information. It was a great
Thanks
night.
a lot for joining.
Thanks. Bye-bye.
Okay. Metin, senle videoyu konuşalım şimdi. Söyle. İdil, ama Özlem sen gidebilirsin. İstersen tabii.
İyi geceler size.
Hadi, çok
teşekkürler.
teşekkür
Çok
ederim.
sağ
Ben de
olun.
çok teşekkür.
Özlem.
Tamam. Metin, videodur zaten.